Good afternoon, everyone. We'll be starting shortly in about 5 to 10 minutes, okay? A very good afternoon to everyone present here. I am Meher Kaur and I warmly welcome you to Respirar 2021 by batch 2018 and 19. This is Steady State, the trauma management workshop, and it just wouldn't have been possible without our faculty who have graciously organized this session for our participants. Respirar began as a state-level conference in 2015, and we have been organizing it as an international conference for the past 2 years. We are organizing this conference for the first time after a long hiatus of 2 years. Thank you so much for being a part of this and celebrating this milestone with us. I would now like to felicitate our chief guest of the day. Our first chief guest is Dr. Girish Chandra B. Bhartake sir. He is the professor and head at the Department of Orthopedics at B.J.GMC&SGH, Pune. A senior spine surgeon with nearly 35 years of experience in the field, with an equally impressive academic portfolio, with a number of national and international publications. He has given several talks and conducted workshops at several conferences, state as well as national level, and is a well-known and respected figure at state as well as national level. Thank you so much for being here today, sir. We also have with us Dr. Sushma Shitore ma'am. She is an assistant professor at the Department of Anesthesia, a clinician par excellence and a stellar academician. She is a pediatric anesthesiologist and a BLS course provider. Thank you so much for being here today with us, ma'am. We also have Dr.Prateek Joshi, sir. He is an orthopedic surgeon with an interest in traumatology and hip and knee replacement. A certified ATLS provider with American College of Surgeons. Assistant professor, Department of Orthopedics, and an enthusiastic UG teacher as well. He has been certified by BSS and CCRISP from Royal College of Surgeons of England. He was also the one who pioneered the trauma workshop for the first time in Respirar 2019. Thank you for being here today, sir. Dr. Shrisha Parthaje ma'am is a senior resident at orthopedics at B.J.GMC Pune. An orthopedic surgeon and a stellar academician with a passion for undergraduate teaching. He is interested in traumatology and sports medicine. I'm sorry for my mistakes, sir, and we are very excited to have you today. Dr. Rishikesh Tupe and Dr. Divya Tomar, they are resident doctors in the Department of Orthopedics. They are enthusiastic and well-read faculty. Thank you so much for being here today with us, sir and ma'am. Next, we have Dr. Samira Dalbhakta ma'am and Saloni Halvide ma'am, who will be our associate faculty for the day. Thank you for being here today. I would now like to call upon Dr. Girish Chandra Bhartate sir to give an 5-minute address. Please, we would be extremely honored.
Good afternoon, everybody. Okay, this is, I think, more a good gathering of the people who are interested in learning. Day by day, I am feeling that the undergraduate students are coming less in contact with the teachers because they are adults and they are more in self-learning. But I'll tell you one message which is very important, that if you want to opt for a surgical branch, it is not a book learning, it is not a self-learning, it is learning by the teacher. So today, do a lot of hands-on the workshops, so which will give you a training to make your further life good. Thank you.
I would now like to call upon Dr.Prateek Joshi sir, who has graciously organized this workshop for us. He has been in touch with all of our coordinators from Despera and has enabled us to provide, all of our participants with this opportunity to learn and upgrade their hands-on skills. Thank you, sir. Please come up and give us a support.
Good afternoon, everyone, and thank you for the opportunity. We just have the PowerPoint up and running in a minute. Okay, so good afternoon, respected chairpersons and all my colleagues here today. At the outset, I'd like to thank Dr. Bhartate sir, Professor and Head Department of Orthopedics, B.J. Medical College, Pune, for giving us this opportunity and giving us this guidance and mentorship, without which none of us would be here at this workshop. So I'd also like to thank Dr. Sushma Chikoya ma'am for taking out time from her schedule and coming to give us an exhaustive talk on airway management techniques, which will happen in the next few minutes. Dr. Sushma ma'am actually happens to be on emergency call today, and she's very graciously taken out some time for us. So let's give both our senior faculty a big hand. That being said, it's my pleasure to stand in front of you and give you a brief idea of what we will be doing this afternoon. So we incepted this respiratory trauma workshop in 2019, before the pandemic era, when coronavirus was just a chapter in the microbiology textbook. And at that time, we had approximately 40 candidates, and we had made it a field trauma workshop. So what we had focused on was how do you handle trauma in an out-of-hospital setting? So with just the bare minimum or none of the actual splints or actual casts which you get to see. And we had ended the workshop by making a reference to disaster management and triage. And after the pandemic, come 2021, we have come a long way. We have broadened the scope of the workshop and we have redesigned it from scratch. And we are now following a globally accepted pattern of learning, which is based on the Advanced Trauma Life Support, that is ATLS module, which has been approved by the American College of Surgeons. I'm very happy to announce that we have a 100% live interaction and a complete hands-on workshop in store for you this afternoon. And next slide, please. So we have 4 stations now. The first station, which is primary survey and ABCDE, which will be run by Dr. Shrisha in this hall itself. Then after that, you will move on to your second station, which is splinting using hospital material next door in clinical lab 2 by Dr. Rushikesh. Followed by that, you will go downstairs to the pathology lecture hall for splinting using out of hospital materials by Dr. Divya. And then you will come upstairs to the pharmac laboratory for the last skill station, which is needle thyrotomy, CPCR, mask ventilation, and intercostal drainage insertion in pharmacology lab, which will be taken by me. Now, before I sign off, another proud moment for the B.J.GMC and Team Respira. Because of the overwhelming response to this workshop, we decided to make it open access and live streaming for anyone who is interested. We are running live on YouTube as we speak in collaboration with Medusane, which is a leading YouTube channel from Tagore Medical College in Chennai. And over 3 YouTube channels, we are now broadcasting to a projected subscriber base of approximately 17,000 students over 65 medical colleges all over the country. So thank you to Dr. Ramanathan from Chennai, who is helping us with the broadcasting. And without further ado, I hand you over to Dr. Sushma Chitore ma'am, who will take over for airway management. Thank you.
A very good afternoon to respected Bhattacharya sir, all senior faculties and students. Myself, Dr. Sushma Tandre, I am assistant professor in anesthesiology, and my talk for the today is overview of ATLS and basic airway management. So this is what is the ATLS. It is the Advanced Trauma Life Support. So it is a course or it is a training for doctors, and here we teach participants a safe and reliable method for the assessment and resuscitation of trauma victims, and also we give the basic necessary knowledge for the same. So we have to go back to the history that why there was a need for a separate training program. So it happened with one tragic incident. One orthopedician surgeon, Dr. Jim Steiner, he happened to pilot his own plane and it crashed in a rural cornfield. He himself had or suffered of critical injuries along with his 3 children. The wife was killed instantaneously. So it was the care that he and his family received was less than the adequate due to the obvious lack of triage, training, and resuscitation of the personnel. So he himself stated, when I can provide a better care in the field with limited resources than what my children and I received at the primary care facility, so there is something wrong with the system and the system has to be changed. So it is not the problem with the resources or the infrastructure, it is the change in the mindset, change in the training, change in the resuscitation strategy, and change in the prioritizing. So he started the course in Nebraska in 1978, which was taken up by the American College of Surgeons and given nationally 1979, the Advanced Trauma Life Support. Now, when we look at the distribution of the global injury mortality, the road traffic accident itself is the leading cause of death worldwide. So we know that more than, or we have found it, that more than 1 million deaths worldwide are due to RTA, and it is also responsible for 20 to 50% of million severe injuries or the life-threatening injuries to the population. That is why, and more than 90% of this RTA, they happen or found to have more in a developing world. That is why the implementation of this program in our setup has a positive impact in reducing the mortality due to trauma, and it also helps in giving a better comprehensive care to the trauma victim. So when we look at the death pattern or the death following the injuries, so they are typically described in a 3 time periods or 3 peaks. So the first time period is within seconds to minutes of injury. So here the nature of injury is the lethal. Very less or nothing can be done for such victims. The type of injuries are severe brain injury, high spinal cord injury, rupture of heart or aorta, and death is imminent. So only the preventive measures will help in such kind of injury. The second time period is within minutes to several hours following injury. So this is our main working area of ATLS training. The concept of golden hour is in this type of time period. So golden hour, as the name suggests, it's the first 60 minutes after sustaining the major trauma.
So it's just not a time limit, but it's a window of opportunity where when we implement the appropriate and rapid assessment followed by resuscitation, then definitely these patients can be salvaged with less morbidity and mortality. So type of injuries in this type of patients or in this time period which leads to death, if not taken care of, are intracranial hematoma, pneumothorax, liver or splenic laceration, pelvic fracture, etc. So such patients needs to be addressed on priority wise. For example, the patients with intracranial hematoma, the initial stabilization followed by craniotomy will definitely change the course of disease. So what are the goals or what things are to be learned in our training? So first is the rapid and reliable assessment of the trauma victims, followed by the resuscitation and stabilization priority wise, followed by the participant also needs to learn the need of the trauma victim, whether it matches the capability of the provider and the resources which are available at the trauma care center. If patient needs an operative intervention and it is not at our care center, then patient has to be shifted to the higher center where he can be operated. If patient needs a good intensive care, he has to be shifted to a better equipped hospital where a good intensive care is possible. And the transfer of such patients within hospital or outside hospital has to be arranged appropriately, and they also have to make sure the optimal care of all this process. It's a continuous one. So in training, the design of the ATLS training program is there is a need of a standardized trauma training followed by a better pre-hospital care, then trauma center with a dedicated trauma team and established protocol to take care of the trauma victims. So this definitely helps in reducing morbidity and mortality and better care of the trauma patients. Now the concept like how we do the history taking, as many of you must be doing the clinical posting. So any patient with chest pain comes, we start with the history taking, that is ODP, onset, duration, progress. So if patient is complaining of a chest pain, then we ask him whether it is a right-sided, left-sided, pricking type or crushing type, whether associated with breathlessness, whether radiating to the shoulder or back. But this is not the case in patient who has sustained the trauma. So the detailed history is not essential to begin the evaluation of a patient with acute injuries. And we should never insist for a definitive diagnosis to start a appropriate intervention. For example, if patient has sustained a chest injury, a blunt trauma to the chest, patient is having a tachypnea, patient is in a respiratory distress, we should not ask for a radiological investigation to see whether it is a pneumo or a hemo. What is more appropriate on our clinical examination is to assist the breathing, is to insert the ICD, then with or without endotracheal intubation. So that needs to be practiced, and treat the greatest threat to the life first. So this goes for the airway event and circulatory event. If they are not taken care of within time, it may lead to the death of the patient. So if patient is having a head injury with obstructed airway and extremity trauma, then the obstructed airway is to be taken care of first. So what should be the approach? The approach is to when we see the patient or when we evaluate the patient, the approach, or we have a mnemonic A, B, C, D, E. So in A, it is a airway with restriction of cervical spine motion. B is breathing. C is circulation. So attempt is to make to stop the bleeding. Then disability or a neurologic status, and E stands for exposure, is to address the patient to look for remaining injuries and environmental control. You will be having a separate session on this. So now we come to the next topic, that is the basic airway management. Now you all are undergraduate students. We don't know whether you will be opting for a clinical or a non-clinical, but this topic and along with CPR is of a prime importance, because being a doctor, being a healthcare provider, you should know this basic airway management. That definitely saves the life. That definitely saves the life. Why the topic is important? As we know that the loss of airway is a critical event. If we do not intervene, it may lead to the death of the patient. And even if we happen to intervene and we secure the airway, but the sufficient time has lapsed, the patient has suffered hypoxia for a long time. So hypoxia for a long duration is definitely correlated with the poor neurological outcome. As you all are aware, brain cannot tolerate hypoxia for more than 3 to 4 minutes, as the oxygen is the important substrate. So even if we happen to save the patient, the neurological recovery is poor. That is why the rapid assessment and rapid intervention is must. The second is the assessment. Then how do we do the assessment of these patients? So when we say or when we look for the airway, we are supposed to look for the patency of the airway. So obviously we have to rule out the obstruction or airway obstruction. So what are the signs that tells us that patient is having the airway obstruction? So they are noisy. Noisy breathing is a sign of airway obstruction. So that can be because of secretions, that can be because of the blood which is present, that can be because of any foreign particle. Noisy breathing, drooling of saliva, hoarseness of voice, stridor, snoring, facial burns, facial trauma, they all are the indicators that your patient's airway is at threat. So you should look after the airway very carefully in such victims. Then examination. Now in examination, like how we go inspection, palpation, percussion, auscultation, the same protocol needs to be followed with respect to the trauma or what is seen obviously, whether it is a blunt or a penetrating injury, is there any evidence of flail chase or subcutaneous emphysema, is there any deviation of trachea, that all need to be looked after. Then is the airway maneuver and airway adjuncts. So this is how we evaluate the airway step by step. We will come later to the airway maneuver and airway adjuncts. And then again, like to know that on field, very less things can be done for the airway. So we can open the airway with the help of maneuvers, certain maneuvers. But other than that, when it comes to a stage that we have to now secure the airway, then we need a airway gadgets. So they may not be available on the field. So patient needs a dedicated setup for the same. So when we talk about care of airway, it is under three heading. First is maintenance of airway, second is oxygenation, and third is definitive airway. So maintenance, as I told you, the removal of foreign bodies, secretion, blood clots, stone particles, just to ensure the patency of the airway so that patient can breathe adequately. Then certain range of airway maneuvers to open the airway and use of airway adjuncts. Then oxygenation to all patients who are breathing spontaneously, but breathing is not adequate, and patients who are not breathing at all, the oxygenation is must. And then the definitive airway. So we have a certain indication when then we should opt for a definitive airway or we should secure the airway. So these are, so now what I'm going to talk is the airway maneuvers. Now whenever the victim is unconscious, there is a hypotonia. So there is a loss of tone of pharyngeal muscle. There is a loss of tone of tongue muscle, genioglossus. So what happens? The tongue and epiglottis falls back against the posterior pharyngeal wall. Like here you can notice that white part is the airway and the red part is the tongue. So the tongue has obstructed the airway. Look at the picture, the airway is not patent. the airway has been obstructed by the tongue fall. So what I can do on field, I can give head tilt and chin maneuver. What is head tilt and chin maneuver? Like I have to palm precisely against the forehead that allows the tilting of the head, and I am also supposed to do the chin lift. So what happens? The tongue moves anteriorly, so it falls off or comes out away from the posterior pharyngeal wall, and it clears the airway. Now breathing is possible. Now, if you noticed, when I perform a head tilt and chin lift, there are the obvious movements at the neck. So in patients in whom we suspect the cervical spine injury, we do not want any neck movement at the time of airway management. So this maneuver is not to be performed if patient is having a cervical spine injury. Instead, in such patients, we can perform a jaw thrust. What is jaw thrust? Is anterior and forward movement of the jaw. So we just lift it anteriorly with the help of thumb and index finger. So the tongue automatically moves anterior, and again it relieves the airway obstruction. And you can notice that there is no neck movement when I perform this maneuver. So this maneuver is to be performed when patient has a suspected cervical spine injury. Now pediatric patients. Now, in an infant or a children up to 2 years, the occiput is prominent. So, and tongue is large, and they have a narrow airway. So, when such child becomes unconscious, they have a more tendency for the airway obstruction due to tongue fall. So, what we have to do, we just have to place a shoulder roll that will extend the head and will relieve the obstruction. And in older children, like how we perform the head tilt, chin lift, and jaw thrust in adults, that can be performed. Now, these are the special group of patients in whom we suspect or in whom they have a cervical spine injury. So, cervical spine injury is to be considered unless and until proven otherwise. Suspect in patients who have a blunt injury above clavicle, those who have a polytrauma and altered level of consciousness. So what is more important is to limit the neck movement, which may damage the or traumatize the spinal cord further. So how do we do or how do we go about the spine protection? I will show you in the next slide. Is the use of the cervical collar. The use of the cervical collar that limits the neck movement. Then we have an inline cervical stabilization. Like assistant can stand on the head end of the patient and he can place his both palms under the occiput and mascoid forces and limit the neck movement at the time of airway management. And also we can give jaw thrust if we want to open the airway. Now, when we are going to, or when we take a decision of endotracheal intubation, we need to have a good mouth opening for the introduction of laryngoscope. Now, the anterior part of the cervical collar may prevent the adequate opening of the mouth. So that part can be taken out at the time of intubation. So these are the airway. Now the next, if maneuver fails to open the airway, and we should take the help of airway adjuncts. So airway adjuncts which are in common use are oropharyngeal airway and nasopharyngeal airway. They are available in various sizes from pediatric to adults. The indication being predominantly the to overcome or cure the airway obstruction secondary to tongue fall. So as you can see in the first picture, this is the oropharyngeal airway. This part is the outer end, this part is the inner end, this part is the white portion which lies in between the tip. So before insertion, we should know the appropriate size airway. If the airway is too small, or if the airway is too large, it will exaggerate the airway obstruction. If it is a too small, it will not displace the tongue away from posterior pharyngeal wall. If it is too large, then it will push epiglottis over the glottis. So purpose is not served. So how do we know the appropriate size? Is from angle of mouth to the angle of mandible. So this is the appropriate size of airway for this mannequin. We have to lubricate prior to its use, and the technique of insertion is the junction of 2/3, 1/3. We introduced like how they have introduced here. Then we rotate it 180 degree and slide it over the tongue. So this separates the tongue from the posterior pharyngeal wall and it opens the airway. This is the nasopharyngeal airway. How do we calculate the size? The size is from the nasal align to the tragus. We lubricate it and then we introduce it into the from the nostrils perpendicular to the face. The contraindication for nasopharyngeal airway, the patients who have a facial trauma, patients who have a basilar skull fracture, patients who are having coagulopathies, the nasopharyngeal airway should not be used. Now, this is one of the mode of, or they are the oxygen delivery devices for giving oxygen to the patient. So they have to be given to the patients who are spontaneously breathing and breathing is adequate. So they are face mask, nasal prongs, venturi mask, and oxygen mask with reservoir bag. Now we come to the definitive airway. Now definitive airway is we secure the airway. Now the airway maneuver, use of airway adjunct over. We need to secure the airway for a longer time to give oxygenation and to take care of the ventilation. So we have to use a different airway gadgets. So we use bag mask ventilation, we use laryngeal mask airway, we use endotracheal tubes, we use cricothyroidotomy needle, and we use tracheostomy tubes. So when we should consider patient needs a definitive airway, again there is a one mnemonic that will help us to remember A, B, C, D, E. A for impending airway obstruction. B, whenever there is a need for ventilation or patient is not breathing. Then patients who are having intractable shock. Then low GCS, they can't protect their airway against aspirations, and then transfer to the hospital. So this is how we do the back mask ventilation. So we need a face mask. Face mask should cover the nose and mouth, and then we attach the umbu. It is a self-inflating device. We squeeze, the air will enter. Air will enter into the lungs, and lung expansion will occur. And if we want to give a higher fraction of inspired oxygen, then we can attach the oxygen source here. So we can give a higher FRP to the patient, and we can also ventilate on room air too. This is the second airway, that is the supraglottic airway device. It places between the face mask and the endotracheal tube. Can be used by inexperienced person. Do not need a really good skill for the insertion of same. And it's an important airway device in the management of difficult airway. All these airways will be taught to you in a CPCR session or hands-on session. Now this is the technique of insertion of LMA. We just have to use a pen grip technique. We just have to hold the tube and advance it over the tongue till we get the resistance. Then we inflate the cup and we ventilate the patient with umbu or breathing circuit. So this is, as the name suggests, they are supraglottic. So they are above the vocal cords. So you can see the placement. Now the definitive airway, the most commonly practiced is endotracheal intubation, but we should have a certain prerequisites before going for it. They are endotracheal tubes. We should have a laryngoscope, umbu bag, spillate, bougie that facilitates the intubation suction machine. After having all the preparations for endotracheal intubation, the next step is positioning of the patient. For me to visualize the cord in a patient who is lying down, my eyesight and patient larynx, they should be in a straight line. So which is not a case in a patient who is just lying down with head in neutral position. So as you can see, this is the oral axis. This is the pharyngeal axis and this is the laryngeal axis. So here in this figure, you can see how they are not aligned. For me to intubate, they should be aligned like this. So to achieve this stage, we give a positioning that is known as the Jackson-Chevalier position, Barking-Gong position, air sniffing position. So what do? We place a pillow or a head ring below the head that gives a partial neck flexion that aligns pharyngeal and laryngeal axis together. And then we give extension at atlanto-occipital joint so that aligns all three axes together and we can intubate the patient. So this is the technique of laryngoscopy. We hold the scope in the left hand, we introduce it from the right side of the mouth, we come in the center, we advance, we see the epiglottis, we change the grip, then we place the tip in the vallecula on either side of the glossoepiglottic fold and elevate the larynx. Beneath, we can see the cord and we can pass the tube. All this will be done in a hands-on session. So this is how the tip of laryngoscope curved blade, it should be in the vallecula, and if it is a straight blade, it should include the epiglottis. This is how is the laryngoscopic view. As you can see, these are the cords, these are the tracheal rings. This is epiglottis, and our aim is to pass the tube in between the cords. So how do we confirm the tube is in situ? So we can do the endotracheal tube placement under vision. Then when we ventilate, we can see the exhaled gases which are moist. So we can see condensation on the inner side of the tube. We can use capnometry. We can detect the exhaled CO2 concentration from the expired gas. Then we can see for the adequate chest rise. And then followed by fixation of tube. Now this is the last slide. So what we saw is endotracheal intubation. Where is the place of surgical airway management? Whenever we happen to face a situation like cannot ventilate, cannot intubate, then we need an emergency airway access. So we have two. One is a needle cricothyroidotomy and second is a tracheostomy. Now tracheostomy requires a preparation, requires the expertise. Procedure itself is a time consuming. We can't have that much of time in patient who is having a desaturation and hemodynamic instability. So instead, we can go ahead with a needle cricothyroidotomy. So as you can say, this you can see this is the thyroid cartilage. This is the cricoid cartilage. The green part in between is the cricothyroid membrane. So we puncture the membrane. Then we attach a 2 cc syringe, take out the piston, attach a 6.5 millimeter tube connector, attach a ambu, and we can ventilate till the procedure or preparation for tracheostomy sets in, followed by tracheostomy. Now this is not an airway access for a long-term duration, needle cricothyroidotomy. This is just to save the time till the more airway is done for the patient. Thank you.
Thank you, ma'am, for that very exhaustive and very now to our stations. So these are the 4 stations. So as we did in the trauma workshop of 2019, we are launching a small little thing called a trauma booklet. So what we have done is we have brought together most of the classifications and most of the data which you will require at hand into one little small A5 size booklet, which can fit into a standard glove box of a car, or it can fit into the dicky of a two-wheeler. And not only does it have most of your classifications of shock, so on and so forth, but also you have most of your emergency numbers, which you will require at the drop of a hat. And a special feature is at the last page, you have a couple of QR codes, which give you addresses to the nearest blood bank, the nearest hospital, and of course, our own institute, that is Sassoon General Hospital. So if you just scan this in your phone, it is going to directly open up Google Maps navigation from your location to Sassoon General Hospital or to Home Blood Bank, Jungle Land Blood Bank, so on and so forth. So I request our organizers to please do a copy of these to our faculty. Each of our candidates will be getting one of these, but we will be distributing the candidate copies at the end of the day. So now I hand you over to Radhika here, who will take over for the rest of the session. Thank you.
Good afternoon. Thank you, Prateek sir, for the overview of the booklet. I hope it is very useful to everyone. Next, we have there are 4 sections. Everyone receive a token? Yes. Whoever hasn't received a token, please. Everybody have one? Yeah. All right. Great. So the first group, that is the ones with the red tokens, are going to be group A. They start with station 1, skill station 1, under Arlene Corman. She will lead you through your stations, and you have to stay seated here right now for Dr. Shisha's lecture. Skill station 2 is everyone with the yellow tokens, right? You are going to be taken to clinical lab 2 with Devanshu Satra. He will lead you to your stations. All right. Then the third group with the green tokens, you are going to be led by Maitreyi Kulkarni downstairs to the third skill station, and the fourth skill station starts off at the pharmac lab, the blue tokens with me. All right, so please follow me. The 4 people assigned are: first set is Harleen Corman, second set is Devanshu Satra, third is Maitreyi Kulkarni, and fourth is me, Radhika Shah. All right, please follow us to the skill station. Can the yellow station come out first and follow the Devanshu? Yellow, everyone with the yellow tokens. Yellow tokens only, please. Yellow tokens. All right. Station 3 has everyone with the yellow token stepped out, please. Has everybody with the yellow token stepped out? All right. Next station is station 3. It is in the pathology lecture hall, 1 floor down. Maitreyi Kulkarni will lead you through it. Yeah. Please follow Urvi for right now. She will take you downstairs. Last skill station, please follow me to the pharmac. Please follow me to the pharmac lab. You may leave your bags here.
Well, it's such a big relief to be back in the conference room now after a short brief COVID break. Well, I'm Dr. Prateek, Senior Resident in Department of Orthopedics. And my intention is to give you some insights about the basics of management of trauma. So as you all know, in a day-to-day practice, in the casualty or in the emergency department, what we go through is road traffic accidents, hanging, homicides, drowning, and other natural calamities. So having the patient with life-threatening injuries, with multiple injuries to be handled with such a short span of time, with the intention of saving life, you will have to prioritize so many things, like patient will be bleeding, patient will not be breathing, and patient will not be conscious, and this confuses the medical fraternity what to handle first. So to manage this, the American College of Surgeons came up with a guideline called Advanced Trauma Life Support. This guideline has a series of protocols about what to be dealt first, which clinical features, which symptoms has to be given priority, and which one has to be dealt later, and what are the primary surveys, what are the agents to it, what are the emergency investigations that you're supposed to do, and what are the preparation you need to have. So my lecture today will be exclusively on the first chapter of Advanced Trauma Life Support System. So since you're all a medicals, most of you are undergraduates, I believe. So sooner or later, you will be handling the emergencies in the emergency ward or the casualty, or else you will be receiving so many calls from your relatives, and like you will be in somewhere outside the medical facility, and you might have to deal with emergencies all through your life, even if irrespective of whatever branch you choose in your life. So I feel that advanced trauma life support training is one of the most basic things that you need to get in your undergraduation so that you will become a good clinical practitioner. So this is the thing that you need to be that we are going to deal with. The ATLS tells us how to prepare, like what are the things that we need to have with us. That is, before reaching the hospital and after reaching the hospital, how do we triage the patient? What are the primary surveys? What are the things we need to see first? And what are the immediate investigations that a patient would need? What are the secondary survey? How do we resuscitate a patient and save life? And what are the post-resuscitation monitors that we need to do? And how do we transfer the patient and till the patient receives a definitive care? This is what we are going to discuss today. So, first of all, let me talk some important things about the preparation. See, the preparation has two aspects mainly, the pre-hospital preparedness and the hospital phase. You are medical fraternity or medical personnel, so most of the pre-hospital management is done by a group of people who take care of the pre-hospital stuff. Those are maybe the ambulance drivers, the staff nurse in the ambulance, or a medical personnel. You should have a good communication with the pre-hospital medical personnels. For example, imagine you are in an emergency department and the ambulance driver or the medical personnel in the ambulance will communicate to you either through a mobile phone or a pager that you will be receiving so and so patient, or there has been happened a natural calamity, there has been a road traffic accident with mass casualties, which might exhaust the medical care that you have in your setup. So prior intimation is very important so that you will have a good preparedness. You will alert your medical team so that you will have enough manpower when the patients flow into your casualties. History. The pre-hospital medical person will take a brief history. It should be so brief that what did happen, how did it happen, how did it happen, how many persons are involved, and what are the injuries. Okay? And he examines the airway in just 30 seconds, that whether the patient is able to talk, is he able to breathe. That's it. He is not trained enough to provide a good definitive airway management. All he can do is to assess and intimate. And it needs, since he is outside the hospital, he is out of the medical reach, he will be in charge of medical equipments in his hand. Also, what he can do is he can control the bleeding. Like, for example, imagine a patient lying down on the road with traumatic amputation of a limb. What he can do is he can take a rope or something, he can tie up a tight tourniquet for that limb and control the bleeding so that he can save a life before reaching the hospital, right? And most importantly, immobilization. So the injured parts, the limbs, neck has to be immobilized properly with whatever local materials available. You have another station coming up next where pre-hospital immobilization will be trained. Hospital phase. Let's imagine the resuscitation area. The resuscitation area or the emergency department should be strategically located. That is, inside the emergency department, you should have a resuscitation area which should not be crowded, away from the patient relatives. You will be often listening to the news that doctors are getting beaten up and so, right? So it should be so strategically located so that you will have a safe working area. And most importantly, I say this again and again, that you should have a very good team. That imagine yourself as a medical officer, you will be the leader of the team. You will have a good staff nurse who is helping you all around the clock. You should have duty workers who will help you in transferring, shifting the patients. And you should have other juniors like interns or other trained medical personnel who can arrange you blood, who can get the investigations faster and mobilize the patient. So the team and working area is most important in this. And another thing is about the equipments. Most importantly, the airway equipments. It should be strategically arranged. Like, you should know that in an airway tray, trolley or in an airway tray, you should have your laryngoscope, all sizes of endotracheal tubes, tracheostomy tubes, the airways, Foley's catheters, then nasogastric tubes, nasopharyngeal airways, laryngeal LMS, everything should be arranged such that with the sizes according to its sizes, so that if you want some 7.5 number endotracheal tube, maybe your senior internist come there and ask you to lift up and give him a 7.5 number tube. You shouldn't keep searching, and because every single second matters, you know. So you should take up, your hand should run so fast that you would be able to pick up the perfect size, whatever your seniors ask for, or your juniors should be trained regarding the equipments available. Other stuffs like pulse oximeters, sphygmomanometers, the availability of investigations like continuous life support monitoring systems, the blood gas analysis systems, etc. And you should have pre-warmed IV fluids. One of the most important thing in management of a patient with hypovolemic shock is that the moment we transfer blood or fluids, the patient loses temperature. If the fluid is too cold, so patient will land up in hypothermia. This further precipitates coagulopathy. What I mean to say is that if you learn, if I take you back to the classes of physiology, you would recall that the clotting factors work at their best in an optimum temperature. Why do we cool the blood products? So that it will be preserved, it won't be acting. The moment you take it back to the temperature of the body, it can act adequately and accurately. So if the body temperature drops down, the clotting factors will not work and bleeding will further precipitate. So pre-warmed IV fluid should be there, and you should have good teams so that you can summon for help and you can call for help. If there is mass casualty, where the manpower will be in short. You should have a team so that they can help you in tough times. So this is a picture where you can see some airway equipments like laryngoscope, the ambu bag, endotracheal tubes, and oropharyngeal airways. So this should be arranged in your trolley, and you should be well versed with it and familiar with your equipments. The next important thing is triage. Imagine a patient or 2-3 patients flowing inside your emergency department. So you should be able to understand the severity and the seriousness of that injury to that particular patient. So what is triage? Triage is defined as sorting or categorizing the patient according to the requirement of medical care for that patient and the availability of resources. So both matters. It is simply categorized that this patient is serious, so we'll take him to the red zone and he will be given the maximum priority. So what are the goals of triage? Why do we do that? What is the importance? Listen to me probably, like if a patient is given priority over less serious patient, a more serious patient, if we give more priority with minimum interventions, the chances of saving his life will be more. It is as simple as that. So the patient, you should be able to pick up the right patient who should be given priority over others. So this is the goal of the patient. And another important thing is adequate usage of hospital infrastructure. So unnecessarily, if a brain dead patient, if you prioritize him and put him in ICU and block a bed, it is going to be a waste, right? So these things are taught in triage. And there are 2 types of triage mainly. One is the field triage decision scheme, and another one is the regular triage that you are going to learn for. The field triage decision scheme is for the pre-hospital personnel. What do they do is that whenever they see a patient, for example, there has been a road traffic accident, and there's a huge list of protocols for them where they are being trained. And what do they do is, let's imagine the patient is having depressed skull fracture, the patient is unconscious, the patient is having proximal limb fractures, like one femur fracture loses blood for around 750 ml to 1.5 liters, one femur fracture. So that is like grade 1 or grade 2 shock, right? Losing 750 ml of blood is grade 1 hypovolemic shock. So if the patient is having multiple proximal limb fractures, that is humerus or femur, pelvic fractures, penetrating injury to the torso, that is chest and abdomen. If he suspects traumatic, if he suspects any concealed hemorrhage, that the patient is pulseless or having feeble pulse, but he cannot really appreciate external injuries, that is blunt injury to the abdomen, where there will be laceration to the soft viscera like liver, spleen, kidneys, etc. So in these times, he will triage the patient and he will transfer the patient to the maximum trauma care possible. That is the nearest, highest trauma center. Fine. If the patient is having some lesser serious injuries, like imagine some tibia fractures or forearm bone fractures, some nasal bleeds, simple nasal bleeds, and some degloving injuries or some simple vascular injuries. So he will refer to a tertiary care setup. And if he gets a walking patient, or he can refer to a primary healthcare center. So these are the things that are being taught in field triage decision scheme. And the thing that we do in our trauma centers is the color coding system. The patients are categorized based on red, yellow, green, and black. The red is the most critical patients who have the chance of saving. We have the chance of saving their life with minimum interventions possible. Like, for example, patient having pneumothorax, hypovolemic shocks, unresponsive patients, having low GCS, Glasgow Coma Scale score is low. So these are the patients whom we categorize as red. Green for all patients who walk into your casualty, who can walk, who can talk properly, who are conscious, we categorize them as red. Somewhere in between, the patients with degloving injuries, patient with the history of like short-term drowning, who are conscious, who are able to talk, are all categorized as yellow. And the black is for dead. I want you to understand 2 terminologies here. One is multiple casualties and mass casualties. Fine. What is multiple casualties? Multiple casualties is a situation where you have many patients in your casualties, but it doesn't exceed the capacity of your emergency department. This is multiple casualties. What is mass casualty? Mass casualty is a situation where you have so many patients so that it exceeds the capacity of the emergency department. Either it may be in terms of the resources, it may be in terms of the beds available, it may be in terms of the healthcare providers, human resource. So why is these two terms important? This is to summon for help. This is to summon for help. Like in case there has been a natural calamity, there has been, imagine there has been a natural around Pune, and you have to alert your team. You can simply message all of everyone and say that we are going to receive a mass casualty in half an hour. So this actually practically happens in our hospital. If you, I don't know how many of you know this. This happens. Like for example, there had been a toppling of a bus in Cartwright recently, and there were 34 casualties which we were going to receive. So orthopedic team got alerted. The entire orthopedic department, irrespective of the unit, irrespective of their designation, they turned up within half an hour, and ultimately we ended up receiving 20 of them, and out of which 10 of them had a very serious injury. So this is very important to communicate. These terms are important to be communicated. Fine. Okay. We'll come to the primary survey and simultaneous resuscitation. I have my heading of my slide. If you can see, this is primary survey with simultaneous resuscitation. You have done the triage, you have seen a patient coming into your casualty, and you have said that, okay, this patient is serious, let's shift him to the red zone and let's manage. The moment patient lands up in a red zone, see, this is, you have to resuscitate, you haven't examined the patient yet. The examination of the patient, the primary screening and management and resuscitation goes hand in hand. It is not like, okay, let me examine airway first, let me see the circulation, BP, then I will think of what to do. It's not like that. The moment you see, within 30 seconds, 1 minute, management should start. This I consider as the heart of ATLS, the heart of emergency management, the primary screening. This is the place, this is the situation where you can definitely decide the fate of the patient, whether you can save him or whether you lose the patient. So this is very important for you. What we do is, the ATLS 2021 guidelines has said that this is the order of priority. Airway first, followed by breathing, followed by circulation, disability, and exposure. A, B, C, D, E, which exactly matches with the sequence of alphabets, right? Fine. As you can see, I have mentioned that airway maintenance with restriction of cervical spine motion. So whenever you are handling the airway, remember that anteriorly you have the trachea, the airway system, and posteriorly you have the cervical spine. The importance is that upper cervical spine injuries, you have from C1 to C7, you have 7 vertebrae and 8 roots. So the nerve roots of C3, C4, C5, these nerve roots form phrenic nerve, 3, 4, and 5. Importantly, the fourth one. So the phrenic nerve, what does the phrenic nerve do? It supplies the diaphragm. So if that gets injured, and if upper cervical spine gets compressed by hematoma fractures, so what happens is that you will lose the patient. Patient will not have active breathing. So most importantly, whenever you are handling the airway, remember that you have got cervical spine posteriorly, and you gotta deal with that too. Any polytrauma patient has got a cervical spine injury unless proven otherwise. Fine. Okay, let's start. First of all, the airway. What I recommend is this 10-second assessment. The patient walks in the red zone. How do you assess the airway? You simply talk to the patient. Make the patient speak for 10 seconds. If the patient is able to talk effortlessly for 10 seconds, you are very sure that the airway is patent. Fine. and ask him what had happened to you and how did you get into the hospital. If he is able to recall the accident or the trauma, and if he can define the chronology of reaching into the hospital, then you know that he is conscious enough, he is oriented enough, and his cerebral perfusion is intact. Fine. So first of all, whenever you get a patient in casualty, make him to talk. If you feel that the patient is drowsy, try to wake him up, tap his face and make him speak. Then if he imagine he is little drowsy, and the moment he started to speak, he starts speaking with hoarseness of voice, or you feel that the voice is not proper, you can look for drooling of saliva from his mouth, or you can look for any facial deformities. Then you know that there has been a compromise with the airway. Okay, so what you should look for is that does the patient snore? Is there any stridor? Does the patient drool? Hoarseness of voice when he tries to speak? Look for facial trauma. This facial skeletal trauma, you know, like if the patient has a head-on collision, facial skeletal fractures, and the dentures might get fractured and fall back into the airway. Patient will choke with his own teeth. Also, if there are head-on collisions, then there will be oropharyngeal bleeding. Patient will choke with his own blood in the airway. So this is very important, and just look for any penetrating injuries near the airway and look for any life-threatening injuries. The importance is that why did ATLS keep airway as the first priority? Because if there is complete compromise of the airway, you will definitely use the patient within 180 seconds. Okay, so it's not just because to be fancy enough to put it as ABCDE, not just because it's the first alphabet of English, it is because that you will lose the patient like this. So it is very important to make sure that the airway is patent. Okay, so as I said before, the management of airway goes hand in hand with immobilization of cervical spine. So what do you have? You can give a collar. To immobilize cervical spine, you can give a collar. There are two types of cervical collars. One is soft collar and the hard collar. What you see here is the hard collar. This particular collar is called as Philadelphia collar. It has got a opening in front. You can see. This is for the place for tracheostomy. Even if you want to go tracheostomy, you can get the tube out of this opening and keep the cervical spine immobilized. And the other one is the spine board. Whenever you shift the patient, if you suspect any spinal trauma, you can safely take the patient into a spinal board. The advantage is that easy mobilization. Imagine you want to shift the patient immediately to an emergency operation theater. You can simply lift this board and take the patient. It has got straps too, so it's very convenient. The other one is log roll. Of course, this doesn't come under the management of airway. I have just put up a slide since we are when we examine the patient actually. So how do we log roll? We need at least 4 people. I'll tell you about this in the end. Fine. And the other one is MILS. This is manual inline stabilization of cervical spine. So what we do is, if you can appreciate in the last photograph, you have a person sitting and holding the neck. Fine. He immobilizes the cervical spine. Imagine the patient is having cervical spine injury with compromised airway. You have decided to intubate the patient. So since you are suspecting cervical spine injury, you cannot simply extend the neck. So a person kneels down and holds the cervical the neck, stabilizes it, and the intensivist intubates him. Okay. This is called manual inline stabilization. So if you want me to put it poetically, I always say my juniors that 3, 4, 5 keeps you alive. Fine. Cervical spine level 3, 4, 5 keeps the patient alive. So whenever you are handling any patient, you are looking for airway. Remember that you have got spine posteriorly. Okay, so few points regarding the airway management. Ma'am has taught you about the head lift versus jaw thrust. So regularly, if you are suspecting airway compromise, you have to inspect first. You have to open his mouth and look what has happened. Is there any secretion or is there any choking? So you have to open his mouth. So how do you do that? The easiest method is to tilt the head and lift the chin. So whenever you tilt the head, you are extending the neck. So this is again a stress on cervical spine. So is it recommended? Absolutely no. If you are suspecting polytrauma, this shouldn't be done as a routine. The best thing to do is jaw thrust. The first photo on the left hand side, you can see that from the posteriorly you simply push the jaw forward. So this opens the temporomandibular joint and you can open this jaw and inspect what is wrong inside. And to maintain the airway, if there is fluid inside, blood inside, you simply do the suctioning and just take a laryngoscope and look for airway. If it is patent or a tongue pressure, you can examine the oropharynx. You have got the airway, the right upper corner, you have got the oropharynx. The man has taught you to introduce. Initially, you should introduce as if you are in a reverse direction. Once you're having advanced 2/3 of it, then you turn 180 degree so that it is directed towards the trachea. Okay, so this prevents the tongue bites and the patient. If the patient is having inadequate, if you suspect that the patient will deteriorate in future, better just put this and you can proceed with your examination. Okay, but the thing is, patient should be having active breathing. If the patient is not having active breathing, then you will have to intubate the patient. So remember that. What are the definitive managements of airway? Endotracheal intubation from mouth directly till the trachea. The other things, as ma'am said, cricothyroidotomy and tracheostomy. Cricothyroidotomy is at the level between the thyroid cartilage and cricoid cartilage. Tracheostomy is over the third tracheal ring. Right? This you have a hands-on session, right? Okay, fine. So the other alphabet. What do you have done? You got the patient. How do you examine? My mentors used to tell in the department of orthopedics that if you don't know how to examine, all you need to do is look, feel, move, measure in orthopedics. But in this, what you need to do is look, listen, and feel. Okay, you have to look for breathing pattern. Look for breathing pattern. Is there any use of accessory muscles of respiration? Is there a labored breathing, difficult breathing? Is there a tracheal deviation? Has the trachea shifted to one side? So then you can suspect there is either an pneumothorax or something wrong. There would be a mediastinal shift. Is there a jugular venous distension? Okay. Is there a paradoxical breathing? So what is paradoxical breathing? What is normal breathing? What happens to the chest when you breathe in? Inspiration, chest expands, and expiration, contracts, goes in, right? Paradoxical respiration is the reverse. When you breathe in, a segment of chest wall falls inside. Okay, so this happens chest in a patient with chest injury having segmental fracture of 2 or more consecutive ribs. That is, rib has to get fractured at 2 levels and consecutive 2 to 3 ribs has to be fractured. So then you will suspect flail chest. The seriousness is that it is a retrospective indication that inside the lung there will be lung contusions or there will be hemothorax or pneumothorax, whatever. So having looked for breathing, you listen. You have got a stethoscope in your hand, just auscultate for breathing. Is the air entry bilaterally equal? Do you able to hear the breath sounds equally? Or is there any decreased air entry or absent air entry? Most critical thing is absent air entry. Okay. And just palpate the chest wall. Feel for any fractures. Whenever you feel, you will feel for crepitus around the chest wall. So that will indicate that the rib has been fractured. So if you feel that all the ribs are okay, then you do compression, anterior posterior compression. Just press on the sternum. Patient will wince with pain, cry with pain if he has got any posterior fracture. Compress from the sides. All these takes less than 10 seconds. Fine? Okay. So what are the life-threatening injuries that you would encounter? First thing is tension pneumothorax. Tension pneumothorax is a single wall kind of mechanism where there is collection of air in the pleura. You will have absent breath sounds, and the moment you diagnose tension pneumothorax, how do you treat him? You should do a needle decompression. What you do is take a wide bore needle, 18 gauge needle or something like that. Just puncture over the second intercostal space in line with mid-clavicular line. Okay. Tube thoracostomy. Okay. In massive hemothorax, there is collection of blood in the pleural cavity. What do you do is tube thoracostomy. You take intercostal draining tube, which we call as ICD. You in the anterior axillary line in the fifth intercostal space. Anterior axillary line in the fifth intercostal space, you do ICD insertion. Okay, how do you do it? You have two ribs. You go on the upper border of lower rib. In the fifth intercostal space, upper border of lower rib. Why do I say this specifically? Because on the lower part of upper rib, you have neurovascular bundles. So you shouldn't be injuring it. So upper border of lower rib, you enter into the pleural cavity and insert an ICD. And the flail chest, I have already told you, and open pneumothorax, like penetrating injuries into the chest, like bullet wounds or stab injuries. So these are the life-threatening conditions. The third thing, very important, is the circulation. So who described the circulation system in human body? Physiology? Yeah, William Harvey, right. So it's very simple. You have got a pumping heart, blood vessels to distribute the blood to the tissues of the body. That's it. So what is shock? Shock is a state of compromised circulation where there is decreased perfusion of tissues of the body, organs and tissues of the body. This is the simplest definition that I can put for. It is the state where there is inadequate perfusion of tissues and organs of the body. So what are the types of shock we get? Hypovolemic shock, like in case of bleeding. Road traffic accident, amputation, there has been a damage to femoral vessel or something. He has lost so much of blood. And the other type is obstructive type. Obstructive type you get in tension pneumothorax. See, you have blood inside your body, but the heart is not able to expand. It is being obstructed externally from tension pneumothorax or cardiac tamponade. Massive pericardial effusion, collection of blood or fluid in the pericardium. 3 layers of heart. The last layer is the pericardium. The collection of fluid of blood is called as pericardial effusion. If it is massive, then it is called cardiac tamponade. Okay, so how do you treat it? There's a photograph. So you take a large bore needle, 18 gauge needle, and just to the left of xiphoid. Okay, just to the left of xiphoid, what you do is you puncture and enter to the direction of left shoulder with an angle of 45 degree to the vertical line, keeping an angle of 15 degree to the chest wall. Okay, you insert it and draw the blood out. This has to be ideally done under continuous ECG monitoring, because if you what if you puncture the myocardium? Okay, the moment you touch the myocardium, there will be changes in the ECG pattern. I think there are some M waves or something like that. So it indicates that you're too much inside. So simply withdraw it and perform pericardial, remove the decompress the pericardium. And the other type is neurogenic shock, like in case of central nervous system injuries, brain and spinal cord injuries. So how do you clinically assess? You have seen the airway, you have seen the breathing, those are all fine. Simply feel for pulse. Pulse will be feeble, thready pulse, feeble pulse, and heart rate more than 100. And take a systolic blood pressure. Systolic blood pressure has dropped below 110. And signs of inadequate tissue perfusion. The signs of inadequate tissue perfusions are cold and clammy skin. Touch the extremities. Touch his hands, touch his foot. It will be cold and clammy. And it will be pale. The lips, the nail beds, those will be pale. And check for capillary refill. How do you check the capillary refill? You simply press over the nail bed. This will go blanched. And the moment you remove, within 3 seconds, it has to come back. Like you press it like this, remove 1000, 2000, 3000. It should come back normally. If it gets delayed, it means that peripheral perfusion has been hampered. So that these are the indirect clinical evidences that the patient is in shock. So what do? The moment you suspect shock, you look for bleeding. So look for any external bleeding, chest wall, abdomen, pelvis, limbs. Okay. And there are two types, like revealed bleeding. You can look for the wound and suspect that this is the site of bleeding and this is where I have to intervene. And the other type is concealed bleedings, like in case of pelvic fractures. Imagine a runover injury over the pelvis. There will be comminuted fracture of the pelvis. And pelvis, the moment you get pelvic fracture, the pelvic venous plexus will be distorted. So there will be retroperitoneal bleeding. So these are the sites where you have concealed bleeding, like blunt trauma to the abdomen. There will be liver spleen lacerations and intraperitoneal bleeds. And you haven't exposed the patient yet, so suspect bleeding in sites like armpits, groin, genitourinary tracts, etc. Intracranial bleeds everywhere. Okay. So how do you manage it? First of all, try to stop bleeding. There is an external wound, simply try to compress and stop bleeding. Apply tourniquet. Like you can see the patient has got a wound, traumatic amputation recently, applies tourniquet and tries to stop bleeding. And skull bleeds heavily, that is because the outer wall of the arterioles in the skull has been attached to the fibrous layers, so it cannot contract. So there, fastly take sutures. So these are the methods where you can try to stop bleeding. And immediately get help of your staff nurse, and 2 large bore cannulas has to be put. IV lines. Secure the IV line in both hands. Large bore cannula means green, gray, or white, like beyond 18, below 18. Okay. And IV crystalloids, 2 liters of fluids, crystalloid fluids has to be given fastly. Okay. What are crystalloids? Normal saline, finger lactate, etc. Fine. And this has to be, remember, this has to be pre-warmed. This has to be pre-warmed. Also, you can give colloids. Colloids are plasma expanders like metastarch, hemosil, etc. And the moment you put cannula inside, draw blood and send it for cross-matching and aid for blood. Blood has to be issued rapidly within 15 minutes. Okay. And you should assess, this is not immediately, you transfuse fluids and assess BP and pulse after 15 minutes. So you can classify the patients as responders and non-responders. Responders are one where you have longitudinally patient starts improving. As and when you give 2 liters of fluid, the BP and pulse improves. So then you can say that the probability of saving this patient is more because he is improving. If the patient doesn't respond, then you should start giving him ionotropes. Okay. The next is assessment of disability. It is simply the neurological, gross neurological status of the patient. Like you throw light on his pupils, look if it is reactive. If it's not reactive, it may be because of intracranial bleeding, transtectorial herniation, midline shift, etc. And gross neurological examination has to be done. Like simply ask the patient to lift his limbs so that you know that power is okay. At least 3 against gravity, at least 3/5, right? So assess that. And there's a scaling called ABPU scaling. Is the patient alert? Is he talking when is he speaking when you give him stimulus, or he's screaming only when you pinch, or is he unresponsive? This is again important simply because you can call your seniors, you can get more help. You can say that the patient is unresponsive, I need help. The most important thing is Glasgow Coma scale. This has been asked in every NEET exam, and this is the most basic tool to grade the patient IS. Like when you communicate with your colleagues or seniors, you can say that this is the patient is this, so we need help. And you need to keep assessing the Glasgow Coma scale in every half an hour. Okay, this is another point. So you have 3 criteria: I, verbal response of the eyes, that is E, verbal response, vocalization of the patient, V, and motor response. So E, V, and M. Remember this: E, V, and M. In increasing order, eyes total point is 4, vocalization total 5, motor response total 6. EVM 456. EVM 456. Remember this. And if you see, I have put a few numbers in red. Total score becomes 456 becomes 15. 15. So the total score is 15. Minimum score possible is 3. Even for the dead, GCS is asked 3. So maximum score is 15, minimum score is 3. If the patient is having score of 8 or below, then patient is in coma. Okay, if the patient is comatose, it should be below 8. So for eyes, if it responds, if patient opens eyes spontaneously, 4. For verbal response, he is closing your eye. Whenever you call his name, he opens his eyes. 3. And whenever you pinch, he opens his eyes. 2. Doesn't open. 1. Vocalization. He is able to speak spontaneously. He speaks and defines chronology of time, oriented, everything. 5. Confused speech. 4. And speaking of inappropriate words, he is not oriented, some inappropriate words. That is 3. Incomprehensible sounds. This is 2. So note the difference between the two. Appropriate words, words but which are irrelevant. That becomes 3. Incomprehensible sounds, like he is making some sounds like sounds out of pain. So this becomes 2. And no vocalization is 1. Fine. Motor response, obeys all the commands. Ask him to, simple way to assess, ask him to show thumbs up. 6. Okay. Try to pinch him. He can take his hand towards that side and push our hand away. This is 5. Flex to withdraw from pain. Like you pinch his hand, he will take it away. Like he is not able to take the other hand and catch your hand, but he simply takes it away. Tries to move his limb grossly. This is 4. Like flexion, he keeps his arm flexed all the time. We are tightly. This is 3. And extension 2, and no response is 1. Okay. And the last thing is E. E for environment or exposure. First of all, you need to strip after having done this airway, breathing, circulation, and disability, you need to strip the patient completely. Take his undergarments and examine for any concealed and cover it properly. And you need at least 2 people. One person to stabilize the head and neck, the other person to hold the legs, one person to push the torso in a single time, like chest and abdomen. The last person will be handling the pelvis and the thighs. Okay, so whenever you roll the patient, it should be like in a single, like you turn the head. No, when you turn the head, the patient should roll like a log. Then you examine for his the entire spinal column you can examine. And you should always remember to cover the patient once you examine the patient completely. This prevents hypothermia again. So A, B, C, D, E, these are the primary surveys. The moment you have resuscitated the patient, you need to do some important emergency investigations. First of all, electrocardiograph, ECG. You should apply electronic patient monitoring systems, life support monitoring systems, like if you have an automatic sphygmomanometer which can display the BP of the patient continuously, perfect. Pulse oximeter which will give you the saturation of the patient and pulse rate, and send the arterial sample for blood gas analysis, and get a bedside radiograph of the patient. Get chest X-ray so that you would know if there is any pneumothorax or pneumothorax. And this is very important. This is called as FAST. What is FAST? Focused assessment sonography in trauma. This is a quick sonography of abdomen and pelvis done at 4 sites. You take the probe, put in the epigastrium, look for pericardium, right hypochondrium for liver, left hypochondrium for spleen, and suprapubic for pelvic region. And the recent update EFAST. E stands for extended focused assessment of sonography in trauma. So you look for right and left chest walls. You would know if there is any hemothorax or pneumothorax. Then take the nasogastric tube, insert it, aspirate gastric juices. What is the importance? If the patient is having blood or fluids in his stomach, patient is not conscious, then risk of aspiration, yes. And catheterize the patient. Importance, you would know the urine output. Again, an indirect evidence of organ perfusion. Okay, this is primary survey. You haven't examined the patient completely. The goal of primary survey is to assess life-threatening injuries and to resuscitate the patient. That's it. Okay, so we are done with primary survey now. And we would move on to, we have done emergency investigation. We have resuscitated the patient successfully. This is the moment to start secondary survey. Okay. Resuscitated the patient adequately and the vitals are stable. BP shouldn't be falling. BP should come back to the normal level or should be in an increasing trend. And then you can proceed for secondary survey. Now, mahol thoda cool ho gaya abhi. Fine. Okay. Now what you do is you take a proper history. You have the patient conscious and you have your his relatives, talk to them, get a proper history. Easy. So ample history, I would say. Easy allergic to any medications. Easy on any medications. So remember this. Always take history of. So easy on medications. Always take history. Had he taken easy on antiretroviral therapies? So always remember this is very important for you. Remember to handle every patient as PL HIV unless proven otherwise. Because no patient in casualty you would know his status, right? So always take universal precautions, wear gloves, masks, glasses, eyewears, all the necessary precautions. Okay, past medical history. Did he have any previous cardiac incidents, cerebrovascular injuries, or did he undergo any surgeries? Thorough medical history is very important. And another important thing is last meal, because you would, if you are planning to take him for emergency surgery, so being nearby mouth for at least 4 hours is important. If he's not, then you would emphasize more on aspiration from the stomach through nasogastric tube, right? So this is important. And events surrounding the injury. Was he alcoholic before accident? Did he take alcohol? Did he do any drugs? So these are all important. Fine. So once having taken proper history, do a thorough physical examination. Now, in the primary survey, you have examined the patient from head to toe, but you did not give detail to small steps, like if there would be some confusion, separations, small wounds, which you might have not considered that seriously. So a thorough head to toe examination is important, having stripped the patient completely. Okay, and this head to toe examination should end with thorough neurological examination. What we had done with the neurological status was a gross one. It was not detailed. You had just assessed the power. Okay, now you look for detail, power, sensations, reflexes, bowel bladder status. And remember, this doesn't end if you don't do rectal examination. Always do rectal examination, look for tone. Then, because in spinal cord injuries, you can indirectly suspect spinal cord injuries, right? So, you have done the secondary survey. Now you know the complete diagnosis, what the patient is having. But it is very important to go through the further investigations like blood workups, CT scans, like you have MCCT scan for brain. There are guidelines for that. If the patient is having more than one episode of vomiting, any episode of seizures, if the patient is having any ear, nose, throat bleeds, CSF rhinorrhea, these are the indications that you should get a head CT, right? And MRI for cervical spine. So pelvic CT, if there is a pelvic fracture. So these are the things that you need to do after the secondary survey. And always call for expert opinion. Head injury, you should need a neurosurgeon. Orthopedic surgeon, pelvic trauma, orthopedic surgeon. ENT, take help of ENT surgeons. So always call for expert panel. Having resuscitated the patient, it's your job that before the patient is shifted, make sure that the expert panel has examined the patient for their particular field. Before shifting the patient out of your emergency department, reassess the patient. Look for vitals. Keep monitoring the pulse, BP of the patient. GCS score once in every half an hour, once in every 30 minutes. And examine the patient again as if you are running through ABCD scheme again. Okay, that is reevaluation. Go through the protocols again, make sure that the patient is okay, and then transfer the patient. It is a crime to transfer the patient in your absence. So always there has to be a medical personnel who is accompanying the patient whenever you shift the patient from emergency department to ICU or operation theater or whatever it is. And lastly, what we do is the definitive care. Being an orthopedic surgeon, I would say that we do, in case of polytrauma, what we do is damage control orthopedics. Like patient with multiple pelvic fractures, we simply put up the external fixator, try to preserve the, try to prevent further bleeding, and try to prevent further progression of disability. And once the patient is hemodynamically stable, we can think of definitive surgeries. What does neurosurgeon do? They decompress intracranial bleeds, they do craniotomies. Okay, so if there is liver, spleen or injury, gastrosurgeon would do. If there is a splenic, irreparable splenic injury, you would do a nephrectomy, partial hepatectomy, or whatever sounds right for me. Like if there is penetrating injury, then resection and anastomosis of bowel, So these are the definitive care for the patients. And always remember, throughout these patients should be having an intensive care management, like he should be under the ICU monitoring. Okay, so this was what I wanted to give insight about. So let's quickly recall. Now I want you to imagine. So was this exhaustive? Your faces look okay, fine, great. Enthusiastic young minds, I don't care. Imagine yourself as a medical officer in the emergency department. You have got a patient inside. Okay, you talk to the pre-hospital personnel who hand over the patient to you. Simply ask what had happened. You have an idea. Okay, it was a road traffic accident. Patient was ejected out of his bike. So patient must have toppled. I should take the patient seriously. It would be a polytrauma. Let me take the patient. Okay, thanks. You take the patient inside. What do? You simply look for patient, try to talk. Okay, this is something serious. Patient is not opening his mouth. Let's take him to the red zone. Okay, you're the team leader now. What do? You call for help. Take your staff nurse, take 2 assistants, the mamas, whoever is available. Alert your team and ask your staff nurse to arrange emergency trolley nearby you. Start. Primary survey. Airway. Is he able to, is the airway patent? Ask him. What's your name? Where are you from? What happened to you? How are you here? Okay, patient is not able to do that. Do jaw thrust, open, there was blood there, you suction, now he is able to speak. Fine. Good, quick. Next, breathing. He is not able to breathe properly. There is labor breathing. Take your stethoscope, you look, there is something wrong, there is tracheal chip. You auscultate, there was absent presence on the right side. Okay, when you percuss, it was a dull note. Retrospectively, it should be a pneumothorax. Fine. I'll do thoracostomy. Right intercostal space with anterior axillary line, with intercostal space, upper border of lower rib. Do a thoracostomy. Okay, you got blood through ICD. Fix it. Why? Like you're a team leader, you should have your assistants to do all of this. By the time you should have moved to C. Fine. You should have at least 2-3 personnel, like medical care personnel with you. You have moved to C. What is C? Pulse, GP, peripheral perfusion, clinical signs. Okay, patient is hypovolemic, he has lost so much of blood through pneumothorax. Fine. What do? You have called for large bore IV cannulas. You have secured both of them, pre-warmed IV fluids, continuous BP monitoring system. Next, D. Talk to patient, ECG alert, ABPU scaling, pupils, Glasgow coma scaling. Okay, now you know who to call. GCS low, something wrong with central nervous system. You need a neurologist. Alert your team. Next, E. Strip, take off the undergarments completely, do a rough gross head-to-toe examination, and cover the patient to prevent hypothermia. Okay, now you are doing adjuncts. Very good. Yes. Pulse ox, ECG, chest X-ray, EFAST, and ABG. Okay. Put a nasogastric tube, IV. Police catheters. Okay. Now reassess. Now reassess everything. Did I do adequate resuscitation? If the answer is no, walk through ABCD again. If the answer is yes, the patient's vitals are stable, I can proceed secondary survey. What is secondary survey? History. Perfect.
Allergy, medication.
Head-to-toe examinations. Okay. Again, you have your patient stripped already. Head-to-toe examination. Finish it. Next step. Now, after the at the end of secondary survey, you should have your patient completely stable. Because now we are transferring the patient for major investigations like CT, MRI, or whatever. This is the phase where transportation comes in. So you should have adequately resuscitated your patient. Okay, fine. Now the expert panel walks in. Neurologists, orthopedic surgeons, ENT specialists, ophthalmologists, everybody walks in. They come in, they do that and proceed. Hand over your patient for definitive management to the expert surgeons or physicians. Right? Okay. So what I wanted to know is that your team matters. Your skill matters. You should be fast, brisk, accurate, adequate. Fine. You should be strictly following this ABCDE, ATLS guidelines. Strict adherence definitely has very low chance of missing major life-threatening injuries, and you would be saving the patient. Every life matters. So the training for this is a hands-on workshop, of course. This is the most informal training that you would get, but I would highly recommend once you pass out as an MBBS graduates, I would highly recommend you to go through ATLS workshop, a proper ACS certified ATLS workshops. Fine, you would do that? Yeah. Yeah, that's right. This is exactly correct. What I have spoken is based on the recent updates. So this is ABCDE, but I would definitely say that C has got an equal importance as A. But in NEET or wherever you get a question, your answer should be A because ATLS 2021. So that's why I had put my second slide, the cover page of ATLS, right? Remember, it is ABCDE. According to 2007, you are perfect. Okay. So, some insights in you? Yes? Fine. Okay, so I believe that how many among you are fine, sir. How many of you are NEET aspirants here? Raise your hands. Don't hesitate. Half-minded people all the way. Pakka. Most of you don't want to NEET. Okay, this lecture is over. We are interacting. Be free. I'm your friend. Answer. If you want to clear NEET, say yes if you want to clear NEET. Yes. Okay. Fine. So I am running through few questions for you. Let me see how much I because this is difficult. The questions are very simple though, so I will help you. Question number 1. In managing head injury patient, the most important initial step is to. If I were in your place, I would look for keywords in the question. Okay, so I have highlighted it. Most important initial step. Most important initial step. Even if you don't see the options, what would come to your mind?
Control scalp hemorrhage.
Airway.
Sir, but the paramedic will do control scalp hemorrhage, no?
Control. Sorry.
Won't the paramedic do pressure, because it says most important initial step.
Initial step, correct.
So when the person is in head injury,
the question is for a medico. Okay. Even if your assistant is doing, you're the team leader, it is as good as you're doing it. Okay. It is as good as you're doing it. You're the whatever happens, whatever goes wrong, whatever goes right, you're responsible. You're the leader of the team. Whatever procedure has been done to you, finally, okay. So the answer is fine. Okay, second question. Establishing a diagnosis of shock must include. This is purely fact-based question. Like their diagnosis means they are either asking definition or criteria. Okay. How many for E? Okay. Anyone?
C.
Documenting hypertension. Okay. That. So the right answer is E. Okay. Evidence of inadequate perfusion of the body's organs. Documenting hypertension is C. Even in syncope, you have hypertension. Okay. Documentation of hypertension is one of the criteria. It is not. It doesn't define shock. It is one of the criteria. So for you to define shock, you should have altered pulse, BP, signs of inadequate peripheral perfusion. Okay, so the best answer in this among these options is definitely E, no doubt. Okay, this is something that I did not discuss, and I don't want to go through the details as well. E, out of 200 questions, you would be receiving at least 50 questions which you haven't read. So let's try our luck now. For the trauma patient with cerebral edema, hypercarbia should be avoided because, okay, so patient is having cerebral edema, that is fluid in brain, fine. I don't know what it is, out of my domain, because I have bore in my brains too. Okay, hypercarbia, all I know with hypercarbia is that hypercarbia causes. Okay. What does it cause before metabolic acidosis? Why does metabolic acidosis happen? Vasodilatation. Okay, the ions move out, that is metabolic acidosis. So, what happens is simplest question possible. The first manual to improve oxygenation. Improve oxygenation. Answers, please.
Certain the need for choice.
Okay. Any other answers? C. C means administration supplement of oxygen. Improve oxygenation, keep oxygen. You had answered it as ascertain the need for chest tube insertion, right? D. If you need to know the chest tube need for chest tube, you should have a diagnosis. Fine. Sometimes, many of the times, even if you auscultate percuss, you would not be very sure whether it is pneumothorax, hemothorax. You would want a X-ray, time-consuming stuff. You will lose the patient like this. So, take a mask, start oxygen. You wouldn't do wrong if you give oxygen. Right? Okay. Last question. Huge question. What my guides, mentors during my NEET preparation told me that if you have a huge question, break the protocols, start reading from the last line. What is the last line? GCS score. They are asking you GCS score. What I know about GCS score is that EBM 456. EBM 456. What am I interested in the question? They are asking me numerical value of EBM. So I should catch up E, B, and M. So blah 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 blah. Pupil, something related to I. Pupil comes in GCS. Oh, sorry. You wait. Hold on. Okay, you're right. Okay. So I'm trying to just to give you some insights of this approach. Pupil important. GCS pupils, reaction of pupil. No. Eye opening, it is not pupil opening or pupil contracture. Eye opening, he has 4 points. Spontaneously opening, for vocal commands, for pain and unresponsive. So this next line will be important for me. His eye opens to painful stimuli. So it is 2. Perfect. Okay, let's move on. He does not follow commands. Again, but he does moan periodically. Incomprehensible sounds is 2 again. Perfect. 2 plus 2 is 4. Let's keep it aside. This question is very tricky. See, his right arm is deformed and does not respond to painful stimuli. Don't get yourself under the impression that the score is low now. Okay. And his hand is got deformed. What if there is a fracture? He wouldn't be able to lift. Right? So, follow the subsequent lines. However, his left hand reaches towards the painful stimulus. Reaches towards the painful stimulus is 5. And both legs are stiffly extended. Does it mean again it's 2? No. If you have 2 situations, the best score is taken. Okay, so total score is 5 plus 2 plus 2, 9. Perfect. Okay, this is the GCS score for you, and the right answer is 9. Okay, that's all from my list. Thank you very much. Any questions for you from me? One important thing I wanted to say that I missed in take-home message is that now you know that what to do, right? Your job is totally incomplete unless you document what you have done. See, every trauma patient that you are handling in emergency department is a medical legal case. Okay, so keep it in your mind that you will be taken to the court someday in the future. So keep it documented. Even if you don't do, doesn't matter. Keep everything documented. Don't miss a single step that you have done. So that is documentation is very important. Okay. Best of luck. Thank you.
So this is the station where we are going to see various orthos and various bandages commonly used in orthopedic practice. So anyone knows about splits, slabs, cars? Have you heard these words? basically orthosis means external support. So supporting your part of the body externally. That is orthosis. Under orthosis, there are various sub-classifications, there are splits, braces. So these are the things which are going to see. So in orthopedics, there are mainly 4 slabs and respective tasks. So what is slab now or split now? The support, which are going to be the covering partial circumference of the arm or partial circumference of the limb. That will be your slab. If slab is made of now plaster of can be plaster of Paris or fiberglass. There are 2 materials, plaster of Paris or synthetic or fiber. The cast is going to cover the limb in a whole circumference. Okay. So, what do you think? Where they are going to use the slab versus the cast? Say in orthopedics, we use the slab. Where are we going to use the slabs? Where the cast? Small joints. Have you heard about elbow? I guess elbow is large. Slab, okay, temporary fixed. As it is a partial circumference, right? We can remove it, reapply it again. As QT in cast is completely covered the limb, that is not easy to remove, right? So, whenever there is a fracture, what happens next? There will be swelling, right? Swelling and pain. If you don't anticipate the swelling and apply the cast, and swelling grows, what will happen? There will be neurovascular deficit. The arteries and nerves will be under compression and speed. About that, initial management or for the temporary use or temporary stabilization, we use the slits or the slabs. Now, for upper limb, there are 2 slabs. Below elbow, above elbow. For lower limb, below knee, above knee. First, we see below elbow. So, what will be the extent of below elbow slab? So that slab has to immobilize the joint proximal and joint distal. Any fracture you are splitting, the principle is you have to immobilize the joint distally and immobilize the joint proximal. In below elbow slab. So what are the conditions we need to use the below elbow slab? Fracture of section. Radius from here to here.
Proximal area.
Proximal radius will be this much only. If the fracture is here, right? Proximal radius, say here. So the principle says immobilize the joint above and below. For this proximal radius fracture or the proximal ulnar fracture, we have to go above it. So for the conditions of the metacarpals, conditions of the phalanx, conditions of the carpals, if there is a carpal bone fracture, right? We can immobilize the wrist as well as MCP, right? In these conditions, we can make. But if there is a fracture of the distal part of the most distal part of the rib, fully slab. In such cases, we use below elbow slab. So the extent of the slab is from the metapophylean to joint, right? And proximal extent is distal of the forearm and the proximal 1/3 of the upper trunk. For the police fracture, we use this slab. But as we have said, police fracture is a distal radius fracture. Why we are not doing the immobilization of the joint above the fracture and below the fracture? You got my point? I said the proximal shaft of the radius. The joint above and below has to be immobilized. In BE slab, if the slab is extended from here to here, here to here, and immobilizing this joint only. So, what about distal plane radius? What is the specialty? Basically, the distal radius is attached to the ligaments. So, that becomes your proximal immobilized. And after that, there will be fracture. There will be this. So, you are immediately immobilizing proximal. So, the extent of BE slab is for metacarpophalangeal joints or the palmar trees. You have to make this joint free, not immobilized. Right? You are immobilizing the wrist. So, palmar trees to the junction of two-third triangles. Demonstrate this. For that slab, we need a POP roll. So what is POP? So what is POP? The task of facts. Chemical formula. Calcium sulfate, heavy hydrate. Okay. This is into the water. What will happen? The water will be added to this, like calcium sulfate dihydrate. That will become the gypsum, right? And when you dip the POP or add water to the POP, that is going to cause the exothermic pH. So after application of the cast or slab, basically we will say that the dirty level. It is the exothermic pH. So the road is like this. Okay? So POP is a powder form implemented on the normal roller band. This is the roller band. Normal roller band. On that, we add the POP. And when you see this is hard, like slightly harder, so that hardness is the starch. We add starch in that. It becomes like this, hard. For upper limb splits, we use 4 inches of the POP. For lower limb splits, we use 6 inches. So anything for upper limb, go for the 4 inches, right? Anything for lower limb, go for 6 inches. Like roller bandages or crepe bandages. Crepe bandage for the ankle, knee, 6 inches. For wrist, elbow, 4 inches. Now, the demonstration of the PE slab. So the extent is from the metacarpophalangeal joints or the palmar trees to junction. Yes. So for that, we need a material that is soft roll. Soft roll. This is a POP roll, plaster of Paris roll, and one roller mat. So slab is going to cover the partially, right? So for that, we have to take the measurement from the extent, proximal to the distance. Here till here, right? So either you can take the measurement to your tape or roughly measurements like this, 1 and 4. For the preparation of the slab, what you do for any roll to use, the unrolling practice, you always keep this part below and the other roll is like this. Unrolling should not be like this. It's very difficult to unroll. Okay. So any roll you are opening, put the strap like this over which the roll has to be. It's very. Now, for soft roll, you take little bit larger, like this. The measurement has to be larger than the slab because it has to cover AC level that will be irritating the skin. Okay. So for that, when I dip this roll in the water. So what should be the ideal length of the water? Means to easily dip the roll. It's 30 centimeter, approximately 30 centimeter of the water has to be there. And the temperature of the water will be around 20 to 22 degrees Celsius. What happens if the temperature is more? Warm water. So the setting time will be what? Setting time in warm water will be 6 degrees. In cold water, 6 degrees. So, what is setting time? As I have said, the POP is in the powder form. So, the conversion of this powder form into the crystalline form, that is gypsum, is known as setting time. That average is around 3 to 10 minutes. So, you have to do all the work of the slab in 3 to 10 minutes. After that, it starts become harder. So, next question will be, what is the drying time of the or cast? To complete dryness is required around 72 hours, 3 days. Right? After 1 day also, if you put finger over the cast, it will be like not complete, slightly better. So to prepare that, the temperature of the water is 20 to 22 degrees Celsius. That is important. For the slab now, I have roughly taken the measurement 1 and 4 this much. Right? Then I have to make the layers. For upper level, around 10 to 12 layers has to be. Around 10. Okay. For lower level, the layer has to be around 15 to 16, like average. Okay. For like obese patient, you may require more. So you have to adjust that. Okay. But averagely, around 10 and around 15 to 16 for lower level. Now, I have to dip this POP in the water like this. Till the bubble starts stopping, but it starts coming, right? Because it was said earlier. After that, just have like this. Cover it. Before that, we have to reduce the fraction, right? And ask your assistant to hold in the reduction. We'll talk about the reduction in detail for the police fracture. But for that, till now, up to this NCPJ is proximal and distal. Proximal one and distal. For any joint to cover, to do the principle of figure of eight. So you do this from figure of eight. Thumb has to be free. Okay. That's Either you can take this with the microphone or you tie it loosely. Okay. The purpose of this splint is just to stabilize, not to compress. So this is the below elbow slab. Okay. Applied on the dorsal. Okay. And execute. After that, you give the sling. Make the sling. Take the roller package. The roll. Keep it inside your roller bandage. Hold it like this. Tie it one part. This first time. This way. This is the way the elbow slab. In a similar manner, we are going to give the above elbow slab. The extent of the slab will be from the metacarpal joints or the palmar piece to the proximal 1/3 and distal 2/3 junction of the arm. Similar way, proximal 1/3 and distal 2/3 or B. Similarly, we can give the slab for the lower leg, below elbow, below knee, and above knee. Right? So below knee, the extent will be from the metatarsophalangeal joints, joints, till feet. For the below knee slab, if you give at the proximal 1/3 and distal 2/3, what is there at this junction? Neck of the finger. Palpate here over the lat. Palpate the patella. Okay. Go laterally. Go down. Okay. The first body point will be the head of the finger. Just below that will be the neck. Right. And that neck is surrounded by the common peroneal. Common peroneal comes from the behind and surrounds the neck and goes to the active part. So if we apply the slab at this proximal extent is up to here, that is going to compress the nerve, common peroneal nerve. So you have to be careful. So either 2 fingers or 3 fingers down from the lower part of the patella to this, or from the neck of the finger, 2 fingers down. That is your extent. Both are just you don't have to compress the common peroneal nerve. So that is the one complication. If we give the slab that compresses the common peroneal nerve, that is going to cause a foot drop. So after any slab or cast, what we are going to check is the neurovascular status of the tissue. Okay, for upper limbs or slabs of the upper limbs, check for the median. So how do you assess the function of this? So there are 3 things. That tests all the nerves. Okay, sign. Okay. Make the piece off. Comes up. That is to test all your nerves. So if you want to assess, if you want to assess all the different 3 parts, right? After that, you have to check for the distal capillary. Check for the vascular status of the distal part. For that, you have to press the fingers. Again, it is. So that is not going to compromise the neurovascular system. You check it. You ask the patient to check it at home. If any times like he is having any problem, ask him to remove. Okay, remove this one. Next is like orthosis. So orthosis, where we talk about so this is Philadelphia collar, okay, or also a cervical collar. It is a semi-rigid collar. It's not totally rigid or totally flexible also. It is semi-rigid. It comes in two parts: posterior part and the anterior part. With the fractures of the cervical spine. To be specific, upper cervical spine. It is used in the fractures of C1 to C5, but most effectively can be used the C. For application of this cervical collar, you should know log rolling. What is log rolling? Exactly. So for that, so when you are moving any spine patient, try to use log rolling because it is a principle which stabilizes the spine, does not allow you to do this. Right? So for log rolling, well, one person has to stay on the front, like on the head side, two on the lateral, and one on the foot side, right? Okay. One can one again. So for stabilizing the cervical spine, what we are going to do? We are going to put the palm under the shoulders, thumb over the lateral, right? We have to hold the back of the ear with the distal part of the forearm, right? And give slight traction, right? The distal part of the forearm, and slightly elevate, not much, and now you lower. Simultaneously, like this. Okay. Now also the spine is stabilized. You see, then another person will slide this the posterior part, the back of the leg. Then tilt the patient supine. Okay. The anterior part is having the hole or tracheostomy. It goes like this. You have to strap. This is the application of cervical collar. Sorry. Slightly bit forward. How do you measure? For measurement, what you are going to do? The base of the mandible. From the base of the mandible, averagely this in the nape of the neck. If you can accommodate 3 fingers, then this has to be slightly bigger. So one is 4 fingers. So 8 from the okay. So this way we can make it. Next one is number base. Okay. Also. So next is clavicular base used for fracture planning. Okay. For so the clavicle, the displacement of the clavicle fracture is what? The medial part goes up because of the pull of the sternocleidomastoid, and lateral part goes down because of the weight of the shoulder. So to reduce the fracture, what I am going to do, I am asking the patient to put the hand over the lower back, asking him to retract slightly, retract the shoulders. Okay. This is going to reduce the fracture. After that, place this brace like this. Like this, but not fastening. Fasten both the straps simultaneously. Okay. This is the clavicular brace. Next. This is universal shoulder immobilization. USI. It comes with one arm pouch. There is a strap. And body strap. Okay. This is used for the proximal humerus fractures and reduction of the shoulder, the dislocation of the shoulder. You reduce it first, right? After that, because there is a chance of redisplacement or redislocation, to prevent that, we give this USI. That is universal shoulder immobilization. How are you going to apply this? Proximal humerus fractures as dislocation.
We reduce it to this source and then
No. We reduce the fracture by the maneuver. Okay, just to prevent the redislocation. Because after reduction, this is going to immobilize the shoulder, not allowing to redislocate. Okay. The arm pouch and strap. So this is what going to allow the movement of the shoulder. Right? No others. Proximal humerus fracture and after dislocation. Clavicular brace. Next one is this is lumbosacral orthosis, TLS, also known as the Taylor's brace. Okay. This is used for the fractures of the thoracic spine from the T4 to upper lumbar fractures like LT. And the mechanism is it gives a 3-point fixation as it is having the abdominal, thoracic, lumbar, and sacral fixation. So it gives you 3 points of fixation and restricts the motion of the spine. Right? By these straps, we are giving the or increasing the intra-abdominal ratio. So that is going to restrict this movement of the spine. It restricts the flexion and extension. Additionally, they are having the paraspinal aluminum bars inside this that they are going to bend and slightly curve to accommodate the spinal curve, normal spinal curve. Then application of this. Again, you can do the same. The patient is fine. Right? In the case of the fracture, you have to again do the log rolling. To do the log rolling. So again, 83 volunteers. One hand here and the other. One leg. How are you going to stabilize? Arms under the shoulder. Fingers or thumb over the clavicle. This is part holding the. Just slightly. Shift. If not full, partial. You put this. Again, someone from other side will do this. So these are the abdominal straps. Okay. These are the shoulder straps. The ideal TLSO must have the upper abdominal and lower abdominal also straps. This tying of the shoulder strap, you need to do again long rolling. Wind this around the again like this and fasten that. Someone has to hold the leg. You do it now. Like this. Tap it here. This is the way you should let the TLS place. So, superior extent of this base. Superior extent of this base is like the angle of the scapula, spine of the scapula. Spine of the scapula corresponds to T3, right? T3. And the inferior extent is till the PSI, posterior superior iliac spine, that corresponds to S2, cervical. Sacral. This is for the T4 L2, right? S2. What about L2? What about below L2? The brace was used for thoracic over lumbar over L2. So what below lumbar? So we LS lumbosacral or lower lumbar fracture. LS bed, I think straps. So the inferior extent has to be in the posterior superior iliac spine. That corresponds to the venous dimple of the venus. Okay, or esculator. This is the additional step for S2 corresponds to the dimple of venus. DSX. That's it. This is used for the fracture of the pelvis. So we have seen immobilization of the cervical spine with the cradle column, right? The thoracic spine with the TLS brace, or upper lumbar with the TLS brace, lower lumbar with the LS bed. What about the pelvic fracture? So we need a pelvic binder. The important thing is the middle strap. Right? So you keep the middle strap at the level of the greater appendix. That how do you palpate the greater appendix? You palpate your anterior superior iliac spine at the level of the waist. You go above, tracing the iliac crest. You go to the highest point of the iliac. From that you press down and find the first. For that, you like rotate the hip. You can feel the rotation, right? This will be your cheek. But at the level of the cheek, you need to foster your middle snap. That is for this. One patient, one subject or one volunteer will stabilize the lower back and upper back, right? Another one will be doing the same. So please volunteer. Then one will be sliding this way. Lower back and upper back. Okay. Yes. Okay. Now. Rest. Rest. Okay. Make sure that the middle strap is at the level of the chin. Fasten the middle strap. Like this. This is again exercise. This way, the pelvic fighter is going to compress the pelvis. So it is used in the fracture pelvis or hemoperineum. So in hemoperineum, it increases the intrapelvic pressure. That is going to compress the artery and stop the bleeding. The next brace is long knee brace. Okay. So this is used in the condition around the pathology around the knee, like ligament tears, right? Anterior cruciate ligament rupture, ACL rupture, PCL rupture, okay, or sprains, any knee sprain. Okay. For that, again, the important thing is the middle strap. It has to be around the widest part has to be proximal. The narrower part has to be lower for the leg and thigh. So over the knee joint, you fasten this middle strap first, and alternately. This is the application of long brace for the condition of the knee. Okay. Next. Next is for the intertrochanter fractures or peritrochanter fractures, like the fractures of the trochanter. For those, we have to use the Thomas plate. Thomas plate is having the proximal wide ring. Okay, that is, and two metal bars. Okay, so this ring is going to make 120 degrees angle with the medial part. So this is the medial bar. This is the lateral bar. This ring is going to make the angle of 120 degrees. Okay. The outer bar is longer. Okay, and having angulation below, approximately 5 cm below the junction of the ring in the bar. That is going to accommodate the greater trochanter. Okay. It is not ideal, but ideally has to have that to accommodate the greater trochanter. Then, how do we calculate the so for that you have to measure the groin or inguinal till the ischial around the anteriorly around the groin and posteriorly taking the reference of the ischial velocity. So whatever circumference comes, you add 5 to that, 5 centimeters. Because to anticipate the swelling, right? There will be the fracture. There will be fracture. So we have to anticipate there will be swelling. The 5 centimeters extra has to be there, and that is the inner diameter, not the outer diameter. Inner diameter has to be 5 centimeters plus the circumference. Then what about this lower edge? This. So For that, length of the rod is calculated from the groin fold laterally at the most lateral point to the heel, plus 15 to 23 centimeters. 15 is okay. You can go to 20. 15 to 23 centimeters. We have to add 20 or 50 to 23 centimeters. Okay, 100 is the length, then 123 should be the length of the bar. So you can ask your parameter staff to take that range of points. So important thing is ring having the angulation of 120, 5 centimeter below. To accommodate the GT, there must be some dilation or the angle. The lateral rod, 5 centimeter plus the diameter, inner diameter. Okay, and 15 to 23 centimeter of the teeth. Now apply it. So for application of polar radiation, for that, give the action. Someone has to give the counter action. Slight counter. So that there should not be any displacement of the body. So if you are putting the okay. See the hand. Slide it. Take the groin. Now lift slightly the lower like yes, it has to go in the inguinal vein. Okay. Now this padding must be kept in such a way that the heel is free. If we keep the heel rest on this padding, there may be chance that there is a ulcer. Okay, over the tendon. So after applying this plate, you roll it or fix it with a roller bandage. Now, keep in mind that the leg has to be slightly internally rotated, because if it is externally rotated like this, it can cause the damage of common peroneal nerve over this lateral bar. Okay, compression of the nerve against the neck of the feet. So for that purpose, you do slightly internal, slightly internal. Keeping the heel free. You apply like this. Keep the knee free. Because if you apply the pressure over the patella, then the patella will start. In the figure of 8. Keep the give that Purna. Finally, tie it. That's this is the application of next is Howard Jones standard is used for stabilization of the patella. Undisplaced fracture of the patella. Okay, that is used around the knee joint and it compresses the upper and lower fragment of the patella. It keeps it compressed. Okay. All for application of the Robert Jones bandage, first is over the medial with the rapid like this. Okay. Now we go above. Okay. Compressing the distal bone like this. Now compressing the upper lower bone. Compress the can strap it with the sticky note. This is the Robert Jones bandage for fracture protection, undisplaced fracture protection. Slab application या फिर break के बाद 5 Any questions?
So when we apply the below the elbow base, like ideally should be
Below elbow stab.
below elbow stab, should be flex the wrist or should be inserted or to insert a
I think this should be okay. How do you see this? If I apply this switch and hold the bandage, it is going to fall like this. Applying the roller, fixing it. And इसको टाइटन करने के बाद ये गिरेगा नहीं. I need to fix this wrist joint temporarily. Right? It's not possible to flex move. इतना ही ठीक है. This is a temporary or just to reduce the swelling. After swelling reduction, we can go for the permanent task that will be more rigid. Yeah, these are braces. Braces you do before plaster, after plaster. There is no need to plaster. What plaster you will put on that? These are just to support the practice. This funny guys with the braces. These are the another methods to immobilize the practice. The plaster. And this guys are back also go the very good demo apply then give again 5 minutes to go. Everybody will come after break or maybe afterwards for 5 minutes. You can apply again.
You have 10 minutes break. You move to the physio mode and we'll distribute the back.
It's streaming, right? Yes, yes. Yeah. Wi-Fi क्या होगा? It's not working.
No, it's been working. We've been checking.
My Medusane said it's.
We've been checking.
1,000 by the end of the day.
How have you not already made an Iron Man suit
For what?
with the plaster?
That's called research thoracolumbar brace. And there used to be also a full body thing. It was called a bachelor's cast. Now you wonder why exactly it's called bachelor.
It's working.
Yes, ma'am.
It's a break. That's why I started.
Okay. It is now in the bathroom hall.
Huh, now it's in the back.
We go to Stream is coming? Yes. Wi-Fi. Wi-Fi is coming. The stream is coming. Okay. Here. It wasn't charging. Set it up and
We will be having a 5 minutes break and we will be resuming back.
Also check for AP and remove it.
Where's the charger head? You have it? This is fully charged. I will take it in the. I'll put it in the back. And Wi-Fi भी अच्छे से आ रहा है. यहाँ पे भी देखते हैं. हाँ, यहाँ पे भी देखो. You ये है ना? आ रहा है ना? I'll just give you the QR. I forgot the password. QR code ले लो सर. Been using it for such a long time. हो रही है ना? आपको क्वेश्चन था? अच्छा मास्क समझ में नहीं आता. तो इसलिए सर
start with the last part of this. Patients after.
This is the third station for local sprinting. Right now we have a break and we can see the whole station after this.
And they need some particularly for that. If you are not aware of entire simply asking or asking whether it makes sense or whether you can pass urine at his will or oral urine at his will. So it's very important to check the bounds of the money. And if you don't know how to so in such cases, coagulations have to be transported. Most countries they have statistics and loading. Such things are not really available in India. So I have got a different kind of just to illustrate the patient has to go and has already single wooden block and you have to roll it in at once and not twist or so this entire body has to be rolled at once. So assuming that person is alive, so we don't be aware of what is the psychology. But also survival ability. So in that case, any rating of food for any dog roll you have to have food. So for the no, I don't. You have learned from my station. And you know how to place your hands. So who will take the heading? Who is going to place them over the trapezius and shoulder, or finger side and the shoulder. Your forearms have to be on the sides of the fingers, over the next side, and some amount of tension on the edge. And this time you should be able to the palm, but not the so you know the thing is, let me move for the person who is the head. Now I need two more people to go over the top and the lower. You have the same question. Yes, one hand on shoulder, one hand on Jesus. Now, the third person, you will cross his right hand, which is waist, and the person who will be sliding the spine cord has to examine once the person that is looking here will give a call 1 to 3 or and the patient is hold it. You have to calculate from the opposite to you to go down and calculate along the spine the entire back so making the it's the power side qualified the opposite present in that and then you quickly slide the board board the straps has straps in the so that once the patient is lower, you just have to tie the straps over it. You can not, keep some amount of cloth underneath. What is the need? Not me, you should know that. So you give them a call. Side you palpate now from back side. On your call, give a call again. Yes, straps or something. You have to go from the go down. Yeah, and to these animals specifically on some theme of the staircase, some stopping with the necropals or inferior substitution. You have to take it all sometimes there can be some vaccination of the language. So that is part of agency exposure and part of exposure is to the language. After you said neurological and developmental, so we have to explore the so you have to identify the path and we have to understand. Yeah, you are understood now. What is for
Streaming, है ना? Turn the video back on. I'm going to go. We're going to take a break now and we will resume at 5:30. So another 15 minutes, 5:30.
Please get your
Break now and we will resume at 5:30.
Perfect.
So another 15 minutes, 5:30.
adults. I dropped out of Reed College after the first 6 months, but then stayed around as a drop-in for another 18 months or so before I really quit. So why did I drop out? It started before I was born. My biological mother was a young, unwed graduate student, and she decided to put me up for adoption. She felt very strongly that I should be adopted by college graduates, so everything was all set for me to be adopted at birth by a lawyer and his wife. Except that when I popped out, they decided at the last minute that they really wanted a girl. So my parents, who were on a waiting list, got a call in the middle of the night asking, "We've got an unexpected baby boy. Do you want him?" They said, "Of course." My biological mother found out later that my mother had never graduated from college and my father had never graduated from high school. She refused to sign the final adoption papers. She only relented a few months later when my parents promised that I would go to college.
I know. It's okay. अब संभाल के. Then we start. And 8 minutes, ma'am. Live stream.
Which are actually available like pre-hospital, crash sites or accident sites, and how we can play an important role in shifting the patient. And why to use this? I have been Dr. Saloni, and maybe in case of the instructions that we have. So I'll be starting. What is a splint? What is a splint? What do you call it? See now, yeah, very good. Right. So splint is in, I'm actually talking about 3 hospital settings. I'm not talking about splints at an orthopedic center. So a splint is any object that is used to stabilize the extremity, to hold it and immobilize it and facilitate transportation of the patient. And why do we need a splint? Why do we need? A splint is required if the patient undergoes any orthopedic injury, has suffered from a fracture, a ligament injury, or a septic. So, why do we need splints? We need splints because a patient who has suffered orthopedic injury or has suffered a fracture, a ligament tear, a dislocation, he needs to be transported to the nearest hospital. But before that, the extremity has to be stabilized. Otherwise, injury may get aggravated, or the patient may actually lose his limb and he may cause further neurovascular damage. So, what are the telltale signs of a fracture? Like, who will need a splint? How will you identify it? So, I'll give an example. I once went to a trek and I saw a group of people and we had a friend who had fallen down and suffered an ankle fracture. I being an orthopedic surgeon, I immediately recognized that in your situation or people who are in paramedical staff, how will they recognize whether the patient needs actually splinters of that limb or not? So patient will usually complain of excessive pain. They will be able to point the exact site of injury. They will have some deformity after cracking of the bone. They may actually be history of some cracking sound or popping sound when they fell down. They may be able to, there may be swelling, there may be abnormal shape, there may be abnormal mobility at the fracture site. They may say there is some crepitus, there is some sound coming in, the bones are clinking. And they may have actually a wound, open fracture in which the hematoma or the bone is coming out of the skin. In that case, you should be able to recognize that this patient needs splinters of this limb. And the purpose of the splint, why is it actually important, is it will reduce the patient's pain, it will prevent further neurovascular damage if there is any artery traversing nearby. The fractured bone ends may actually compress and tear them further, or there may be sometimes nerve injury. In mid-shaft humerus fracture, for example, it is very common to get radial nerve injury, which travels through the spinal root. So the fracture ends may impinge the nerve or even break it. Also, in some cases, such as femur fractures, patient may have catabolism if not immobilized properly, and patient may present in a better state or with neurovascular, CNS changes, patient will be drowsy or maybe detached. So, splint is of utmost importance. Now, I'll tell you what are the orthopedic principles to follow at the time of injury, since the material that you could be using may differ. So, at the site of trauma, maybe in some forest or in a trek or somewhere outside the hospital, you may not have exact splint or fabric or exact material which may be foldable as you have seen in station 2. You may have simple sticks or belt or umbrella or your wooden household stuff or ropes. So how to help the patient in that condition and help him to be transported safely to the nearest hospital? I will, first of all, when you see a patient at a site of trauma, you should be able to follow the 8 principles of ABCD. First of all, check airway, breathing, whether the patient is able to speak. If he is able to phonate, then obviously he has patent airway. Then breathing, if he is having this difficulty in breathing, there is excessive abdominal distension, where he is having stridor, noisy breathing, or for circulation, if the patient is cold and pale. So after assessing ABC and vitally stabilizing the patient, we move on to D. What is D? Yeah, disability and deformity. So disability can be neurovascular damage. Patient may not be able to move his limb. He may have suffered spinal injury or some peripheral nerve injury. And patient may also have deformity. That is, he may have a fracture and may have maybe having inability to move the limb. That is disability. So today we will cover how to fix that, how to explain that before shifting. First of all, you should see whether the patient has open fracture, closed fracture. If there is open fracture, you should put direct pressure on the wound and compress it, stop the bleeding, apply some dressing or some piece of cloth. If it's still not stopping, you should try it immediately, proximal to the site of injuries. Then if the bleeding is stopped, then you should proceed with the splintage. So after identifying the site of injury, as I told you earlier, based on the symptoms, this deformity, abnormal mobility, identify the site of fracture, and then you have to splint the fracture, one joint above and one joint below that. You have to stabilize and immobilize both the ends of the bone. So in case of a forearm fracture, you have to immobilize both elbow as well as wrist. Also, second thing, you have to then check for the pulse and the neurovascular nerve state of the patient. In case of humerus fracture patient, as I said, we have this drop. So you have to, after identifying the site, you have to check if the patient has this drop. You have to ask him to move his wrist. And also you have to check pulse. If a patient having open injury, you should check the pulse distal to the site of injury. And based on that, you can also gauge approximate systolic pressure of the patient. As you all know, radial pulse is absent below 90 mm of mercury systolic pressure. That also gives an idea of generalized vascular status of entire body. If he is having generalized hypotension, then maybe there is a site of bleeding that you have missed. Maybe there is some circulatory collapse, impending collapse that you have missed. So before disability, you should fix that. That is more important because the patient will die of vascular collapse rather than the forearm fracture. Then also if a patient has absent pulse of radial artery, suppose, you should go proximal to it and check whether there is brachial pulse present or not. If that is also absent, then you have to go to carotid pulse. So carotid pulse is usually absent below 60 mm of mercury. So that gives an idea of whether there is generalized circulatory problem or is it just localized to that level? Is it related to the fracture? Should you provide traction and try to do something to improve circulation of the limb? Sometimes the bone may be impinging on the vessel and circulation will be compromised. So while fixing the fracture, you have suppose identified the forearm. Yeah. Suppose you have identified the fracture as the forearm. You should give traction and check for the pulse. Suppose it is present before applying the splint. Now I'll ask my assistant to hold the limb. You have to immobilize it. And I will now prepare the splint according to the side of the normal limb. So supposing his normal side, because after injury the bones will be overriding and the limb will lose its normal length. So you have to size it according to the normal side. As you have learned in station 2, for forearm fractures, you have to go from proximal palmar crease to approximately junction of each of the arm. In our setting, in pre-hospital setup, you may not have a flexible splint, so we may have to sometimes work our way around with bones, with sticks or rulers or even umbrellas. Whatever is available in your condition, you should take that. But important part is to follow the orthopedic principles. The neurovascular joints and mobilization is important. So I am now using it till below elbow. Supposing there is distal radius fracture and applying it on the volar aspect. Now I'll size it on the normal side and then apply it on the injured side. I will tie it with the elbow. I will tie it off with the help of a piece of cloth or bandage or whatever scarf or anything that you have in your setup. Then I will after securing it, I will reassess the pulse. Whether if sometimes because of tight compression bandaging, patient may lose his pulse and you may have to revise your splint. So what if you feel the pulse is gone after applying a splint? Was there some problem in your splintage? You should then remove the splint, recheck the pulse and reapply it, or maybe sometimes give traction and realign the bone fragments if possible. Also in upper limb fractures, most of the time the limb is hanging down because of gravity and patient may further have pain and injury because of hanging of the limb. So usually a sling is given around the neck and tied around the forearm. This is done for almost all fractures of the upper limb, and we will be using this sling for almost all splints of the upper limb. So after forearm fracture, so you have understood, ideally this should be going above elbow, but in our setup, since we don't have a flexible stick, we have used it below elbow, and for preventing the elbow flexion extension, we have used the sling around the neck. So you have sort of immobilized the elbow joint, and obviously you have immobilized the wrist joint, right? You understood? Now I'll move on. Now I'll move on to mid-shaft humerus fractures or even elbow dislocation. In that case, as I said, radial nerve palsy is common, so you have to check for this drop. And you have to immobilize shoulder as well as elbow for mid-shaft humerus fractures. So you will size it on the normal side from the shoulder. Ideally, it should be going above shoulder to immobilize it perfectly. But it's, in our setup, we are using a scale which is reaching up to the acromion and up to the elbow, and on the on the medial side, obviously because of the axillary region, this will be shorter. You have to size it this way, and you have to keep it on both the sides of the arm. Give some amount of traction. Yeah. Give some amount of traction, and then I will tie this around till approximately the shoulder. If possible, you should go till the middle of clavicle. That will provide active immobilization. And after tying off, you should again check for his drop. Now let's assume I have tied it up till here and I have provided a sling also. Yeah. So we are clear with arm fractures. Now I'll move on to proximal humerus fractures or shoulder dislocation. If you all are not aware of the maneuvers for reducing your shoulder, it is recommended not to fiddle around with the limb, and you should strap it to the chest. Just like we did for body strapping, you have secured and tied the injured side with the normal finger. We use immobilization, similar principle in shoulder dislocation or proximal humerus fractures. Using such, we will be using one chest arm bandage which will traverse the shoulder, and we will tie it off on the opposite side across the chest, and we will support the elbow also, again going one down below. We will support the elbow also and tie it up on the opposite side, and for the forearm, to prevent the hanging, we will give a sling. You have to adduct the arm, medially rotate it. Tie it off across the shoulder. Longer so this will be going across the shoulder. And I will use one across the elbow. You should support the elbow. And strap it across the chest. So, and one sling for the neck. This is the safe position to shift the patient to a nearest hospital, and this will immobilize the injury site. Also, which is a nerve which is likely to get injured in proximal humerus fractures or shoulder dislocation. Yeah, you know how to check the sensory and motor innervation of that. You're aware? That's an deltoid and pedis, right? Now moving more proximally, I'll now tell you about clavicle fractures, which is a very, very common fracture. How do you immobilize? Have you all read? Figure of 8 bandage bandage. Yeah. So before fixing the splint, you have to ask patient to keep his hands on the waist. You should also give actually a mid-axillary padding, but in emergency situation you may not be having it. It's okay to have a sling only a figure. You have to start from the injured side Supposing the right clavicle is fractured, I will begin with the right side. I will go across to the opposite shoulder. I will come up. I will go again down here. I have made a figure of it. And I will go across this plane. This move. And I will tie it in the center. Is this clear? It should be firm and tight. There should be no movement. And you have to again give an anti-kinetic sleeve. Now we'll begin with lower limb fractures. Commonly, we can have patients usually have tibia, fibula fractures or femur fractures. Patient may have ankle dislocation. Usually, ankle is a stable joint and doesn't dislocate without having a fracture in the same settings. So, patient may have bimal fracture or trimalleolar fracture with subluxation of the joint and may require immobilization. Also, if we go proximally, patient may have intracapsular or extracapsular neck of femur fracture, which is very common in elderly patients. Even in your homes, you may have some grandparents who may have fallen in washroom or bathroom and may have injured. And the telltale signs, do you know how does they present? How do they present? What is the position of the limb after neck of femur fracture? Correct. The limb is externally rotated, which is almost in extracapsular fractures, it is almost touching the couch. The lateral border of the foot is touching the couch. That is the telltale sign of proximal femur fracture. So you should identify that and immobilize it using whatever material you have at home. For tibia fractures, you have to go one joint above, that is knee, and one joint below, that is ankle. You should use whatever material is available at your condition. You can use a pillow and tie it with a rope. Again, you should be able to palpate anterior tibial artery, posterior tibial artery. You should know the dorsalis pedis artery. I'm sure you all have read all that in physiology. It is very common, especially in ankle fractures, and you should check it before and after applying a splint. Also, in proximal tibial fractures, patient may have which injury, which nerve is common to get injured. You should check that also. You can also use umbrellas and sticks, and in some outside trekking or some conditions, you can use them. Again, following the principles that I told, measure on the normal side and apply it on the injured side. For femur fractures, an ideal setting in hospital setups, we use Thomas splint. In outside hospital settings, you can sometimes use inflatable splints if you have, or you can use some makeshift splints with the help of bamboo or some sticks which are available at the trauma site. You have to measure it from the patient's groin till the ankle, on the lateral aspect going above the GP of the femur, greater trochanter of the femur, and on the medial side from the groin till the ankle again. Patient can have, ankle can be free since you are immobilizing one joint below, which is knee, and one joint above, which is hip. You can slide it under, you have to give traction, but all the way feeling the pulse, slide it underneath. You can place it back, tie it around with some piece of cloth, and again check for the pulse. Now moving on to ankle fractures. Ankle fractures, usually we use ankle binders in hospital setup if we want to immobilize. The foot has to be in neutral position. The ankle has to be in neutral. It should not be dorsiflexed or plantar flexed. The two pillars to stabilize the ankle joint, the medial malleolus and the lateral malleolus, usually they can get fractured for the ankle joint to subluxate or to dislocate. Dislocation is there, subluxation is common. So you can use external pillars to stabilize it, and obviously after exposing injury, checking wound, checking pulse on the normal side, you have to go one joint below, go till the calcaneum, obviously because we want to immobilize the lower joint, subtalar joint also, and one joint above. If the injury is above syndesmosis, you should include knee also. If the injury is quite distant, you can use below knee splint. That is good enough. You can use belts or any piece of cloth to make a figure of 8 bandage, just as we did in clavicle fractures. Okay, so starting from, supposing we are starting from the ankle, from the sole, we go above, slide it underneath, bring it up back, across the ankle, and then in the figure of 8. So patient should not be able to plantar flex or dorsiflex, right? And tie it off with the help of bandage. So I'm done with demonstration. You have any doubts? You can come here and try it out now. We will start with upper limb and so one group, do we have tall boys who can stand on this side? So you can start, other than you go on this side. You can start with body splinting. Start with arm and shoulder on this side. Can I have bandages? No, it's one. There was one with not yet. This one is for. Both the side is not important. Only one side is also okay. But is the extent okay? Are you immobilized metacarpophalangeal joint? You just slide it, yeah. And you have to immobilize distal interphalangeal joint as well. Now, one person can hold it, the other person can help you tie it. You can have the help of an assistant. Elbow, you have to immobilize. It's okay if it comes down. It's okay. You have to keep it. I would suggest you to first apply the sling around the neck. One of you do it. Who has heard it? Yeah. Now you can try the forearm slam. Where is the stick? Color? Stick. In your ruler. Yeah, two joints should be immobilized. Since we don't have a flexible sling, we are using a ruler here. Approximately, you are immobilizing elbow with the help of neck sling, right? The patient will not be able to. So you can take it proximally and immobilize the shoulder, support the shoulder. The principle is, yeah, you have to prevent movement at the joints. That is important. And these scales will prevent lateral motion, right? Can I have a, yeah, this one is for, you should actually take it around the thumb, so it will not slip out.
Like that one.
Around the, yeah, around the thumb you can go around. One person should hold and one person should apply. You have to hold the fracture distal as well as proximal. Support the full arm. Just don't hold at one side, otherwise the fracture site will clean. You keep one end of the cloth. Yeah. Keep one end of the cloth here. Go above. Ideally, your bandage and your splint should go till the middle of clavicle. In our setting, we don't have a flexible splint, so I am there should be some way to keep it adjusted. This is only to, there's no hard and fast rule, this is only to immobilize shoulder. You understand? If you had more length, yeah, so actually it should keep you will learn in orthopedics and primary care. If you want to prevent it from you flag is exactly. That is why I told you what is the sign. Is the patient having, there's this patient who, when she lifts her hand up, there's a point, there's a point. Patient will have pain, have an open fracture, patient you will have crepitus, there will be abnormal mobility at the fracture site. If you try to move the limb, you will see that the limb is moving here. It should ideally be moving only at the joints, not at the fracture site. That signifies both the cortices have reached. So the limb is moving. For both. For open fractures, you have to first of all control the bleeding. You have to apply direct pressure. If it's still not stopping, you have to use tourniquet and then go ahead with bandaging. Also, your bandaging should not be very tight. You don't want to, disrupt the vascular supply. Also, it is very important to apply splints because if you leave the limb unattended for a very long time, because of excessive hemorrhage, patient may result into compartment syndrome. We all know what that is. Yeah, there is increased pressure because of the facial compartments and excessive blood or edema fluid from the fracture site. The neurovascular damage can happen, and that usually happens after quite a lot of time. If a lot of time has passed from injury and patient has been unattended. And what are the 5 P's of compartment syndrome? We all know. Yeah, paresthesia. So patient will initially have a very tense, swollen limb, which will feel almost hard, like stone. His skin and will be very shiny, and you will not be able to palpate. Sometimes patient may have pallor, pulselessness also, and capillary refill will be abnormal. It will not return quickly. They will be sluggish. Pinprick will be sluggish. Patient will have paresthesia. If still not attended, may result in paralysis. And one more 50. Yeah, pain out of proportion. If you are using if you are hyperextending the limb passively, and the patient is complaining of out of proportion pain, gross pain, then that signifies patient may land into compartment syndrome. And why is that important to identify? You want to shift the patient to a center where there is a vascular surgeon available. You don't want to shift him to a nursing home where there is only primary first aid available. You want to shift him directly to a center suitable for him, right? Please proceed. One of you tie the clavicular bandage. Who wants to try? Yeah, figure of 8. Who wants to try? Ideally, when you use a wide bore needle, suppose a green needle or a yellow needle, and you prick suppose you're not able to feel the pulse, and you still are able to see that the limb is slightly cold, and you are suspecting vascular injury. So these are the signs you will check whether there's actually a vascular injury. Sometimes perfusion is still present. The limb has been, there is collateral circulation has developed, and patient is still able to, the limb is still somewhat warm, even though there is no pulse. So pink perfused hand if there is present. So that is to check, even in the absence of pulse, do you have perfusion present at the site in the limb? Will the limb survive? So that is to check the survival, expectancy of the survival limb. You can prick the fingers with the help of a white bone needle and check if there's spontaneous bleeding. If it's sluggish or if there is absent pinprick, that means there is a compromised vascular status, right? And sometimes even like say about 2 days later, sometimes the vessel is not broken, it's not torn. There is only kinking at the fracture site. So after maybe 24 to 48 hours, the collaterals, they will open up and the shunts will open up and the perfusion will still be present. So you can, gauge the prognosis of the condition and then inform to the higher center. You may sometimes find a patient who was injured or unconscious for 2 days, was unattended in some jungle. How will you know what is the time of trauma or how much what is the vascular in that condition? It's important. Pinprick, capillary refill, pulse, pallor, pain out of proportion. You should know compartment syndrome. And they should be, fissiotomy has to be done immediately in that. If you have a cell, she is not possibly contaminated. Fissiotomy can be done if you know the if not, then it's actually said that it's important to save the limb than to think of infection. There are many methods of, based on the type of dislocation. There can be anterior, inferior, posterior dislocation of shoulder, and there are many methods. The usual protocol is to be traction, external rotation with abduction, then adduct and medial rotation. That usually, but there are many named methods also, like gravity assisted strings and shoulder rotations and but in case you're not trained in reducing the joint, it is better to immobilize the joint and let a trained person handle it. The purpose of this session was to help you all in knowing how to transport the patient safely and not aggravate the injury. You cannot maybe cure the injury, but you can prevent further aggravation. You and then what proximal you have. Yeah, you can use the ruler also, but is the extent of ruler good enough for the fracture? Are you able to? You can use it. It's not actually wrong, but the idea was that it's too close to the joint. It will not be able to immobilize shoulder completely. The chest arm bandage will provide better immobilization. The extent of the slab is too close to the fracture side, right? You're too close to the fracture. You should have some amount of. Yeah, these are lateral supports to prevent varicositis at the fracture side. Anybody wants to try shoulder strapping? The two slings across the shoulder. He has already made his own volunteer. घर से सब्जेक्ट लेके आने का no, not obviously you don't want, if you don't know the maneuver and you're trying, you can injure brachial plexus, you can injure your. It is better to leave it as if it is strapped, and after shifting to higher center, you can level it. Yeah. At the injured side, from the injured side, you can try. So now, if you don't know, yeah, you have to go about it. Now, you go across, and then you bring it upwards. From the back side, no, take from that note.
So now if you don't know how to reduce it, you can immobilize it in the same position as the fracture.
Yes, that will prevent pain and further neurovascular damage.
So
Not
you can
everybody
break
knows the
that,
maneuvers.
so you can break the order first you reduce, then immobilize, then you fix. So if you don't know, you can first immobilize.
This is just for transportation of patients. Treatment part is not yet started.
Right.
Okay, now lower limb splints you all on the side. Anybody wants to try ankle? Any cloth or any belt? Your hand for this. No, bigger one. Yes, this is okay. You have covered the subtalar joints already. And supposing the injury is intrasynesthetic, somebody can hold it for her. You can have assistance in that. This is all for practical purposes, you know. As I told you, I had seen a patient at visa 4 and I had to mobilize him. No, not for that. You have to start at one end. Just as a studying time, keep it at one end. Go up, above, underneath, then bring it up, then you can it around. And it should be in neutral position. That is important. Up to the knee, that is to the end of clavicle. Yes. Both the fingers are buddies, so you start them. Metatarsal fracture, so which is the distance? So what is the extent of the you can improvise. See, in a trauma setting, you can improvise your own space. You just have to understand the principles. You just have to understand what is the site of injury, which is the joint above it and below it. You can make your own splint with whatever material is available at your trauma site. It is an object which is used to hold the extremity in a stable position in case of an orthopedic injury. To immobilize and hold it stable. And after this also you will check for the pulsation. After applying also. BPA to move. BPA is inside, no? Doesn't? Okay, so postulated artery is situated behind medial lateral against distal end of the block and anterior tibial arteries. BPA is between the first and it gets down. Okay, now we'll move on to, you are all satisfied? Now we'll move to very important topic, which is spine injuries. In B, there is one more part, disability. So if you all don't know the exact neurological assessment of the patient, now you have to become psychologist. Please lie down. So you went to jungle, you found a person lying down, he fell from height, you don't know the injury status, he's able to speak, but you don't know what injury he has suffered. You ask, just for crude assessment of the neurological status, you can ask him to move his limbs. So he is able to move his fingers somewhat and his toes, but his other limbs are not moving, the elbows and other joints are not moving. So you are suspecting a central nervous system injury. If he is able to speak and there's no obvious facial trauma or head injury, you are now suspecting there's some cervical or some spinal injury, some dorsal or lumbar spinal injury. If the patient has upper limb injury, then upper limb neurological involvement, obviously there is cervical injury. And if patient has only lower limb, then there is possibly a dorsal or a lumbar injury. You can ask the patient for whether he is able to sense your touch sensation. And if you are well aware of this reflexes, you can check them also. Ask if you can hold urine at his will and pass it at his will. That is to check bowel bladder and urine. After that, now you're thinking of shifting into a higher center. So how will you immobilize the spine? If you are not aware, suppose you are in a jungle, you don't have space. Yeah, you went to Vizapur and somebody fell from height. What will you do? You can make, you can use many wooden logs and make a spine board sort of and tie them together, just like you make a raft, as you may have seen on television. And then, or if you have a plank, wooden plank, you can use that. So the important concept while shifting a patient of spinal injury is to move the entire body as one single log. You don't want to twist the body, you don't want to flex the body, you want it to be as one stiff stick and you want to turn it as one stiff stick. You don't want any movement. And while turning the patient, you will obviously proceed with your ABCDE part. You will expose the posterior aspect of the body, you will check for injuries, you will palpate from directly, starting from the occiput, palpate or for tenderness, any obvious step, any palpable fracture, any bruises, any wounds on posterior aspect, that you all have to check. So, have you heard about manual inline stabilization in your second session? So, I need a team of 4. We can rotate ourselves. Who will be there at the head end? Who want to be there? Who will be there holding the torso? You want to be part? Yeah, sure. You are also there. And who is on the opposite side? You are there. Yeah. Shift is fine. So, for manual inline stabilization, most important part of the head of the team of the 4 is the person at the head end. The person who is holding the neck will give a call and only then you will rotate the patient. Otherwise, the other team members have to follow his instruction. You have to make a C sort of with your hand. You have to place your, no, don't make him flex his leg. Okay, you are quadriplegic, don't move at all. So your thumbs have to be over trapezius and your fingers have to slide down behind the shoulder and your arms have to be at the sides of the ears and the master process, right? You have to bend down to this level and don't flex it, don't do anything. Yeah, you can shift into the edge of the table for purpose of demonstration. In jungle, you won't have any edge. Yeah, just for practical purpose, you can shift. So, the second person will keep his hand over the GT of the femur and one hand over the shoulder. That's on the opposite side. Keep the one that you are holding the torso. The third person will hold the rest of the body. Who's there? You keep your hand one on waist, crossing your hand, right? Keep your hand here and keep your other hand here on the calf. Now, at his call, when you say 1, 2, 3 roll, she will palpate the entire posterior aspect starting from occiput downwards. You will check if there is any injury. You will expose, obviously, you will check the spine, and then you will slide down the board underneath him. And ideally, in foreign countries, there are straps attached to this board. In our setup, if you don't have, you can obviously keep some cloths underneath it. And because after once you slide the board, you can't lift it. So you need to have some straps underneath it beforehand, before you slide it down, right? So on your call, start. No. Everything you have to be at the level. Keep it up. Keep your hand. Yeah. You palpate now. Yeah. There's no tenderness. You have checked everything. Okay, now you have to slide it down, and on your call, on the call of the first person, you call back.
1, 2, 3.
Yeah. And then you don't need to enough. Then you have to apply the straps, and if you don't have, you can place some sort of cloth and then for cervical spine immobilization, you should ideally have a collar. If you don't have, you you can place some sort of pillows by the sides of the legs to prevent lateral rotation of the spine. Understood? You need to have 4 people, you need to have the spine, but if you don't have, you can tie the locks together and slide it out. Whoever wants to try to do it. Any doubts, any questions? No, you look at it also. Who will hold the torso? Who will hold the lower side? No, not like that. Like one hand should be on the shoulders, one hand should be on the GP. This side. Yeah, and this is here. Yeah, not crossing, right? Yeah. So on her call, 1, 2, 3. It was already on spine. So he did it. You understood the placement of hands and importance of rolling. Even if the patient doesn't have a fracture, you can still use the splint to decrease pain, and even soft tissue injuries you can reduce with the help of splints. You have to provide minimal traction, not much, just to prevent the deformity, just thinking of minimal traction. Any questions? Anyone has doubts? Done? You all will be able to manage? Okay, now go to the Thank you.
Please be seated here only.
Thank you. Station.
Working?
Yes, I've been investigating
What we need to do that many. Oh, nice. Sure. Very nice.
ऐक ना, हे रेकॉर्ड होईल ना?
Started with. Okay, is everyone there? How was the other session? It started. It started? Okay, so just check the camera. The looks for that is also adjusted.
Yeah.
Okay. So this is, I think, the last session of the day for everyone, and I hope everyone is not too tired or too sleepy. Even if you are, you will not be for too long, because this is going to be the last and most hands-on session. So what we are going to start off with over here is basic resuscitation maneuver using a maneuver. So the first maneuver which we are going to learn over here is called the chin lifting jaw thrust maneuver. Now, if you have read this maneuver from, just increase the height and the angle is also adjustable. So it goes up here. So chin lift and jaw thrust. This is something which you have read in and you have heard in our first lecture. So what you have to do is, the importance of chin lift maneuver is to deal with tongue fall. Now, whenever you have a patient who is presenting to you in the casualty, you're not going to have them in a hyperextended position, because this is a non-physiological position. Now, what you have is basically a patient who is just lying there with their neck in a neutral flexion, neither extension nor flexion, but in a neutral position. And in that, the tongue is going to fall behind. Now, in you and me, even when we are sleeping, you may be sleeping, but your gag reflex is not sleeping, and therefore you don't have a tongue fall. Who has tongue fall? Number 1 is alcoholics, number 2 is obese patients, and number 3 is patients with any other cause of respiratory or central nervous system depression, which is your head injury, which is cervical spine trauma, which is anyone where respiratory center and the cortical center, the frontal cortex, is depressed, because of which what you get is a tongue fall. And tongue fall is the reason of airway obstruction. So now you started with ABCDE with Dr. Shesha. So what we probably gave you as a take-home message was that, come what may, don't change the sequence. A for airway comes before, B for breathing comes before, C for circulation, so on and so forth. And therefore, when you're dealing with your chin lift and jaw thrust, what you are dealing with is A for airway. So what you have to do is, what is important is hand positioning. Now here it is very easy to just flex it. It's very simple. But the point is, when you are dealing with an actual patient, the patient is going to be bigger and broader than this, and most of the time the patient is going to be say not either inebriated, or the patient could be in a stupor, and so their entire body weight is something, their head weight, their body weight is something you could deal with. So hand placement is very important. You also have a rowdy or an uncontrolled patient, someone who's agitated, in which case you have to hold on to the bony landmark. So the first bony landmark that you have to hold on to is the angle of the mandible. So take up your little finger and hold it on the angle of the mandible, and the other three fingers just come in front of it. See your index finger, which is sitting on the chin. Now, what you have to do, the thumb can either just be there, or you can hold the sinus. Depends on if you have any facial injury or not. If you have some facial injury, just stay away from it. If not, you can hold it over there. And the first thing to do is to execute the chin lift by flexing your wrist like this. You understand? The movement is at your wrist, and from the patient's point of view, the movement is in the first two vertebrae, which is the atlanto-axial joint and the occipito-atlantic or atlanto-occipital joint, which is the occiput C1, C2 junction. Okay, so you have that. Followed by that, you have these two fingers on the anterior part of the mandible, which will execute a jaw thrust. Remember, don't make the mistake of doing all these things together. That's not how it works. Hold this, hold the bony landmarks, execute the chin lift first, followed by the jaw thrust. Is everyone understanding? Chin lift first, followed by jaw thrust. Okay, so let us practice this. We have this, and this. We have three of them with an extendable thing. So please divide yourselves, and I'll be supporting. That's my photographer. Don't do the jaw thrust before the chin lift. Okay, what you are doing is you are lifting the you are thrusting the jaw first. Okay, so what you do is first hold the jaw, flex your wrist. So long as this distance is maintained, you would not move the mandible. Flex your wrist first, and then these two fingers will pull out the jaw. See how they are doing. So what you have to do is you have to keep it happy. Also, what you're doing is I tell you why, especially right now you're and then somebody is not sure. So don't let your fingers get fatigue. If you see this fatigue, so hold it. Take the hold it. What surface area you use, the less of the muscle you contract, the less fatigue you will have over the Sorry, finger first. Everything else will fall into place. This should be the flex your wrist, execute the chin lift, followed by the jaw. Okay. So yeah, come on, everyone from the set, you can see. Next, bag and mask. The purpose of arranging things in this particular sequence, if you can see the sequences on the board behind you. So the purpose of this is that you have a particular sequence in which you are doing things, and for every skill you need the skill before. So if you want to do bag and mask ventilation, you can't just come here and put that bag and go ahead. You have to have a chin lift and jaw thrust done. Followed by that, you can put a bag and mask. Why? Because there is no point in pushing air through a bag and mask if your tongue is blocking the lower air. It is like flogging a dead horse. It's not going to work. So because of that, you need to first execute a chin lift followed by a jaw thrust. And now what you're going to do is you're going to change your finger placement a little bit. So now once you are done with putting the chin lift and jaw thrust with your 4 fingers, now what you have to do is leave this finger, leave the index finger. And instead bring fingers in the same place, the other 2 fingers here, and chin lift, jaw thrust. Then what you have to do is place the mask. This is a job for 2 people. This is not a single rescuer algorithm. This has to be done by 2 people, and this has to be placed here. Now, please take a look at this mask. This is not your standard mask which you're used to seeing when you see those commercials of people admitted with COVID. You don't see that. What you are seeing is a air seal mask. The ones which you are seeing where you see someone has the mask on in a hospital, that is just a low flow oxygen mask. What you are seeing here is actually a air seal mask because of this part, which is a partially inflated air seal. So what it is going to do is it is not only going to sit on the nose and mouth, but it is going to create an airtight seal from which you can inflate. Now this is a makeshift kind of lung which we have. The bag should inflate if the air is going in properly. So what we are going to do is first adequate placement of the mask before we execute the entire maneuver I'm going to show. That is the upper part, this apex of the mask should sit on your bony septum of the nose, not the cartilaginous septum, because cartilaginous septum will get deformed. Bony septum will provide a good amount of feedback, and then this will mold itself around it. An adequate size mask is one where this sits on the bony spectrum, the bony septum, sorry, and the rest of it will sit in the mental fossa over here, right? So now what we're going to do is we're going to execute a chin lift and jaw thrust. I'm going to keep it here, so I'm going to get the back. Yeah, and what we're going to do is what we're going to do is your 3 fingers here and use the surface area of your index finger and thumb to hold the mask in a C fashion. Exactly. Again, don't use this. If you're using this, your fingers are going to get fatigued, and this happens in a workshop like this. It's fine because you're just holding it for 30 seconds. In actual an ambu ventilation scenario, you probably will have to hold it for approximately 15-20 minutes. At this point, and want your hands to get tired. In which case, you use this surface area, create a seal. So the chin lift and jaw thrust will be done and create a seal. And now, what she's going to do is she's going to attach the mask, and when you see the air getting inflated, which means that there is a perfect seal here. If I leave it, the air is all coming out from here. So what we need is a perfect seal, and watch the bag getting inflated. Understand? In one of those mannequins, the bag is very nice. You can get a chest. So let us start with it.
और ऐसी पोजीशन में उसको रखना। इसमें समझ में आएगा कि सब करेक्ट है।
It's inflating. I have to concentrate. But if your patient is good, don't stress your use the entire surface. Perfect.
कैसे लेजर डिप्रेशन ऑफ द माइंड कितना क्या 15 to 16 ना इसको देख
As everyone does, what even is So now we are just going to deviate a little from the sequence. We have manual incline stabilization at number 4 and then fluoroplastical airway at number 3. What we are going to do is manual incline stabilization first. Purely for the reason that someone asked, what do you do with cervical spine injury? So I think all of you have these notebooks. There is one thing which I wanted to write down, please write down. That is, cervical spine is assumed to be injured in polytrauma until and unless proven otherwise. Okay, until and unless proven otherwise. Why? Because number one, if you have gone through what Dr. Srisha taught in ATLS or the ABCD, is there any mention of cervical spine X-ray? Far end. Cervical spine X-ray. Nothing. Secondary survey. Exactly. Not in the primary survey, not in the list of life-saving things. It is not there. The only thing that is left is that you have to clinically examine, which will have its own set of policies. And if you have a whiplash kind of an injury, then even if you do an X-ray and it is normal, the MRI findings will take 24 to 72 hours to show up. And therefore, because of that, you have to assume that cervical spine is injured unless proven otherwise, which means unless normal MRI, normal neurology, normal X-ray, everything, only then you can say that fine, this patient does not have cervical spine injury, which means from the point of view of acute stabilization in an acute trauma setting, all cervical spines are injured. Okay, and therefore all cervical spines have to be stabilized. Now, up till the 9th edition of ATLS, which was in 2018 or 19, what we used to have was immobilization of cervical spine, which is no longer a part of ATLS. Now, what we have changed the terminology to is restriction of motion of cervical spine, because it was recognized that you can never have a completely rigid mobile cervical spine. So, because of that, what you have is cervical spine motion restriction. Okay, so and what you're supposed to do is called as inline stabilization or manual inline stabilization, MILS. So what you're supposed to do now, this is what I was asked in when I was training for ATLS, and they said, how will you immobilize the cervical spine? And very confidently I went and I did, and they said, so the thing was that what you have to do is you have to stabilize from the shoulder upwards. So what you have to do is either hold from the side or hold from below. You have to insinuate your palm under the shoulder, and what you have to do is use your forearms to press the head. What you need to do is to use your forearms as a sling. You cannot have a single point where you are holding the head, because the head is so large that even if you hold at a single point, that point becomes the fulcrum and the cervical spine will still move. What you need is linear stabilization, or what you need is the entire arm to ankle splint. So what you do is you hold it like this, and then when you hold it, now it may happen that you're trying to hold here and the patient has an injury at the shoulder, at which point you can hold it from the sides and still you can immobilize, and then my assistant here will do only and only a jaw thrust maneuver without chin lift. So what you will do is you will just, you will not lift the chin, you will just insinuate your fingers under the angle of mandible and pick up the jaw. So now what you have done is that the spine is stabilized and the movement is only at the temporomandibular joint. And what you have done is you have managed to immobilize the occiput C1, C2 complex, and therefore you will not have any problem while you are inserting the airway or doing anything. Apart from that, another question which is asked very frequently is, when do you do this? When do you do this? The answer to that is the first thing you do when you walk into the casualty is go and catch the patient like this. Why? Because if there is a patient, and you must have learned in airway management where a speaking patient is a sign of a patent airway. So now if this fellow is there and he has some very cervical spine, and I'm standing over there, and I say, hi, how are you feeling? And you turn around and you say, I'm good. That's it. There goes your manual inline stabilization. So before you do anything, before you say anything, before you engage in any conversation with the patient, first go catch the patient like this and say, okay, what happened to you? This is what you do. First thing that you do is MILS, which is manual inline stabilization of the entire cervical spine. Followed by that, again, just like your bag and mask ventilation, this is also a 2% job. So one person stabilizes the spine, second one executes a jaw thrust. Now, before we move on to the hands-on part of it, one more thing which I want to teach you is airway. This is a oropharyngeal airway. This is not intubation. Unfortunately, the mannequin is not designed for intubation. So we cannot do, because for intubation, you require a mannequin with a tongue, because you need to push the tongue aside. So this mannequin is designed for airway insertion, but not for intubation. Airway insertion is for patients who have a tongue fall. So you could have an obese patient, you could have a somnolescent patient. What is a somnolescent patient? A patient who is drowsy. So you could have an obese or a drowsy patient, or what you could have is a patient who has some sort of a central nervous system cortical depression, where the patient's level of consciousness is altered and the tongue is falling back, in which case you need to insert this airway. What you have to do is, please note that the pharynx goes like this. First thing first, you have to size the airway, which means you have to put the airway of the appropriate size. Exactly. So the size, there are 4 landmarks which you have to see. One is angle of the mouth. Second is alanasi. Third is the tragus, and fourth is the angle of the mandible. So angle of the mouth to angle of the mandible, alanasi to tragus, or in some cases angle of the mouth to tragus. They are roughly the same amount, plus or minus 0.5 centimeters. The currently accepted standard is angle of mouth to angle of mandible. Measure it like this. It should reach, for the people standing this side, measure it like this. And insert it, don't just push it inside. Unlike an endotracheal tube, which goes in like this goes in the opposite direction. Put it inside. It will go along the roof of the mouth, along the hard palate, till a point where you have negotiated past the hard palate. Now, once you have negotiated past the hard palate, you are in line with the trachea, but this is pointing in the opposite direction. All you have to do is just turn it through 180 degrees and push it inside. Why do we do this? It sounds like one of these medical terminologies is unnecessarily complicated. It's not like that. It is because in a patient of tongue fall, if you directly push this, you are pushing the tongue further down. It's not solving your problem. Whereas what you have to do is, this will go along the roof of the mouth. By definition, it will be above the tongue. Then you have reached the trachea. Again, the tongue is inferior to this. Now you are just turning it around, and it's going inside. Now it is pressing the tongue underneath it. So it's gone like this. Tongue is further down, and there you go. You have a patent airway. The question is again, one more thing which everyone from the last 3 batches has asked is that what you have is what kind of oxygen supply do you put on this? What kind of tube do you put on this? The answer is none. None at all. This is a definitive airway. It is not an orotracheal intubation device. No. This is used for a patient whose airway is not patent, which means something is coming in the way. Tongue fall. It could be laryngeal edema, secondary to say an anaphylactic shock. Not in our case. In case of trauma, if you have a patient with burns, if there is soot on the inside of the larynx, it will trigger inflammation. You can start off by putting this and see if the patient's saturation is improving. What is the prerequisite for this? Patient is spontaneously breathing. A spontaneously breathing patient, this is just a title. A spontaneously breathing patient will be the only one who is benefiting from this kind of an airway. After which, if the patient is not able to spontaneously breathe, you have to just push this aside exactly and go for orotracheal or endotracheal intubation. Is everyone understanding? So this is not a replacement for intubation. This is an adjunct pre-intubation where you are trying to create a patent airway. What is the advantage of this? You can, number one, it keeps the tongue down, so there is no more tongue fall. Number two, this is nice and patient. You can suction any secretion through this instead of suctioning them directly through the mouth, where you would kick off a gag reflex. Okay, so let us do this. Everyone do MILS, everyone do the jaw thrust, and everyone do this. Now, this and this are perfectly sized. They have a little bit of discrepancy. So one of them has a smaller airway and one of them has a grossly large airway. If you are not able to rotate the airway, it turns for this one. You can, because see, that's the thing, right? Okay. But one of the things, MILS, George.
So there's 3 more members. First thing is chin lift. In line. First thing is flexion. Okay, then under the chin, yeah, I'm just teaching. This is the now one this is the yeah, front air. With your index finger here and your thumb, you hold it in place like that. And then something else, you take the arm back. You push it down here to create a rest. Yeah. But you see, normally see it. Okay. Those are the 3 things that we focus on. The last one is the so have patient that has cervical spinal injury. You assume that all patients have spinal injury. So you will not use the head with the chin lift, yeah, because then that will go this way. So you stabilize the cervical spine by putting your hands under the scapula and your thumbs over the hips. And your hands will stabilize by the so now your entire cervical spine. Then someone else will come and not do the chin lift. That is moving to the cervical. So you don't do that. While I'm doing this, I need you to do the jaw hands. Just with both hands are just first the jaw. That's it. You're not doing this. That's it. Put it down. Down now. That's it. Now you take the foot all there. Hold it with one hand, take the chin up with one hand, and put it like this. You're trying to keep everything. If the tongue is falling back and it's like this, you're going to push it back. So you first introduce it like that. Then once the past turn it 180 degrees. And then you push it like that. And this should be the how to measure it. It's from the mouth to the angle of the mouth. Yes, because we're trying to move it past the back, the posterior one third of the tongue into the back. And this is not
Click photos of it while doing that. While saving that. What are you doing? And like
by the limited now. Okay, we have it's 7 okay, is everyone done? Is everyone done? Okay, for the organizers. whoever missed out on all this, once we are done with the vote of thanks, we can quickly run through everything. Dr. Divya and Dr. Rushikesh are already teaching downstairs. We can join them there. This, if anyone wants to do, I will teach them. Okay. So yeah. Yes. So can we now move the camera over there because we have the surface marking slide. On a yeah.
I'll get you the.
No, it goes on its own. No. So now this is a pure demonstration session. What we are going to do is surface marking for your cricothyrotomy, which is your needle cricothyrotomy and your surgical cricothyrotomy. It will come from this side because whoever is standing behind is not going to understand anything. Now, first and foremost, if you remember, we have the Adam's apple, which is the tip of what? Below that, what do we have? How broad is the cricothyrotomy? Approximately equal to your 4 fingertips. Roughly that much. It translates to somewhere around 2 to 3 centimeters. Depends on your size and personality. So it is approximately 2 finger breadths. Now, what you have to do is remember that your cricothyrotomy is an approach. Tracheostomy is the procedure. Okay, so cricothyrotomy, what is otomy? Is to open. So cricothyrotomy is an approach and the tracheostomy is the procedure. Okay, so what we are doing is the cricothyrotomy approaches. There are 2 ways to do it. Number 1 is needle cricothyrotomy. Number 2 is surgical cricothyrotomy. Now, in the textbooks as well, there are 3 things which you will read. One is needle, of course, one is surgical, and there is something called as emergency cricothyrotomy. Now, remember that there are emergency cricothyrotomy, there is elective cricothyrotomy, no doubt. The elective tracheostomy and emergency. But for needle cricothyrotomy, it is always an emergent indication. There is no place where you would just walk up to a patient and say, now I'll put a needle in my face. No, it is only to establish the area and get the air flowing while you prepare for surgical cricothyrotomy. Elective, of course, is there when you have, say, total cord palsy, you have something that's like, you have a patient who is stabilized, but you would like to have some more chronic or more long-standing airway for the patient. Then what you get is the elective cricothyrotomy. Steps are the same. The difference between elective and emergency is only the setting or only the environment in which you are doing it. Otherwise, or the indication for which you are doing it. Otherwise, it is the same. So let us start with needle cricothyrotomy. What you have to do is palpate here. This is the upper border of cricoid palpate. Palpate here. This is the thyroid notch, isn't it? Adam's apple, not the thyroid notch. What you have in between is the cricothyroid membrane. What you have to do is in the midline, approximately between the lower 1/3 and the upper 2/3 is your point of entry of the needle. What you have to do is you have to get a broad gauge needle, which is approximately the one which we are using for very complex, or the ones which we are using in pediatrics, even the small ones, they are very narrow. This is broad, this is 14 gauge. There is a bigger one which is 12 gauge, and there is one size smaller which is 16. So if anyone asks you which are the needles you will use for this, it could be 12, 14, 16. Okay. Now, what we have to do is take the needle and insert it perpendicular at this point, which we have decided, which is upper 2/3 and lower 1/3 junction in the midline, in the cricothyroid cartilage. Push it and get the loss of resistance. Why? Because the loss of resistance indicates that you have cleared the membrane and you are in the trachea. Now, if you were to go further, you will go into the posterior border of trachea, which you don't want. So, at the point of loss of resistance, just turn it at 45 degrees and go into the and It is the highest setting that you can have on that flow meter is 15 liters per minute, which means you have to push in oxygen very high. Right? Why? Because this is an interim measure while you are getting ready to perform what is a surgical cricothyrotomy. Okay, the surgical cricothyrotomy is what you will be performing. This is an interim measure, so you will push in oxygen. Now, remember that you have to do what is a longitudinal midline incision, that is the same line on which we put this marker just inside the skin incision, just inside this particular line, which is a longitudinal midline incision on the from the lower border of thyroid cartilage to upper border of cricoid cartilage as per your palpation. Followed by that, once you open up the skin and soft tissue, this going to look something like this. You have used an artery forceps or blunt section of the finger to push all the soft tissue aside until you get what is the cricothyroid membrane, which is going to be something like this. Right. Now, what you have to do is take a horizontal incision. The earlier skin incision, remember, was a vertical incision, and now what you have is a horizontal incision. Number one, in any surgical procedure, no two surface incisions should be parallel to each other because it forms a single area of weakness. So one incision gets the one forward will, these two will protect each other. Second, now you are facing the membrane. You go a little extra down, you will end up nicking the cricoid cartilage. You go a little up, you will end up nicking thyroid cartilage. So the safest thing to do, just go parallel to both of them, isn't it? So you make this incision, use an artery forceps, open it out. You are in the lumen of the trachea. This was surface marking for needle cricothyrotomy followed by surgical cricothyrotomy. Last part of the session is surface marking for chest tube insertion, and this is not something you will require at undergraduate level of theoretical knowledge, but you should know this clavicle. Here you will palpate for the second intercostal space, second, third, fourth intercostal space. This is the mid axillary line. This is the anterior axillary line. You are going to make an incision approximately in the fourth intercostal space here. Parallel to the ribs again. Why? Because neurovascular bundle is at the lower border of the abdomen. So again, if you don't want to nick it, just go parallel to it. Just think you're doing surgery, whatever you want to say, look for it and go parallel. So parallel to the ribs, and your entry point for your tissue is again which is between the intercostal space. This was your marking. So if you want, so please, yeah. Okay, no problem. So this is your anterior axillary line. This is your mid axillary line. What you're going to do is make an incision in the fourth intercostal space parallel to the ribs, and here at the junction of anterior 2/3 and posterior 1/3 of the space between the anterior and mid axillary line, you will make an entry point for your chest tube. So there are 3 more mannequins here. If you want, you can go and draw and mark out. Since these are solid mannequins, we do not have a chance to put in the chest tube. Hopefully by the next time respirators is there, we will get solid mannequins. Okay, go ahead. Hemothorax, pneumothorax, anything in the pleural cavity. What we are talking about is pneumothorax. Pneumothorax earlier used to be decompressed by in the mid second intercostal. Whereas now, according to ATMS, that incision was both intercostal space with clavicular. Upper border of lower border of lower. Or you can think the point to parallel and not perpendicular. Okay, you have these and you have it is the same side where you want to train. Whatever, be it pain, be it blood, whatever you can do, so whatever the pathology from one side, be it okay.
Everyone will come in 2 minutes.
Yeah. We move into
Chaitanya.
नहीं है अलग है अलग है
again, you take care.
Should we come in? Take it to the main hall. This is your hall.
Wi-Fi निकाल
We'll do this after photo conference. Like अभी कराऊंगा मैं Can you hold us? Excuse me.
Damn.
उसका अच्छा है, बहुत अच्छा है। वो जैसे बोल रहा था almost delay. Checking if I can see my hand. What is fine? This camera. आपको इधर से जाना है, करो क्या नहीं होती क्या? What channel is it? You say it. थोड़ा भी दिख रहा वही तो वैसे भी नहीं
Thank you.
कनेक्शन है बैटरी था ना
But Wi-Fi is on. मतलब इसका sorry.
Okay, good evening, everyone. I hope you have all enjoyed this workshop and found it informative. I would like to conclude this workshop, vote of thanks on behalf of the organizing committee of Team Destiny. I would like to extend my heartfelt gratitude to Dr. Girish Chandra Bhattake sir, Dr. Sushma Sitode ma'am, Dr. Prateek Charuchandra Joshi sir, Dr. Shirsha Parthaje sir, Dr. Devya Toman ma'am, Dr. Rishikesh Tupe sir, Dr. Samira Dhaval Bhakta sir, and Saloni Haluna ma'am. I would also like to specially thank Dr. Balaji Chinnaswamy sir, the Professor of Pediatrics at SRM Medical College, Chennai, for lending us his streaming platform and helping us share this wonderful workshop across the nation. For the guidance your concise and informative demonstration and lectures will surely help us all in our career. I would also like to thank the organizers of Team Restaurant, who have all worked with great enthusiasm to ensure the smooth flow of the event. A special thank you to all the participants for their participation in the workshop and the viewers for making this workshop a success. Thanks a lot. And, please make sure to collect the certificates and the booklet after the workshop.